Good morning. On behalf of Bradford Health Services, welcome to today's interactive webinar presentation entitled Grief, Trauma, and Addiction, Concurrent Sources of Pain. My name is Zach Ludwig. I'm the Vice President of Clinical Services and Accreditation for Bradford. I will be moderating today's session, assisting with chat and Q&A functions, and facilitating questions if we have time for them at the end of today's training. Today's session is a continuation of our quarterly webinar series that we started in 2020. If you've been joining us routinely, you will know that it's our goal to bring you timely, high-quality educational content in an accessible manner. If this is your first time joining us, I extend to you an additional recognition and hope that you will continue coming back in the future as we continue to expand our webinar offerings based largely on feedback and requests that you send to us. Before I introduce today's speakers, I want to share some important information about today's training. You're viewing this session in the webinar format, which means that you can see the presenters, but your video and audio are off. Please use either the chat or Q&A functions located at the bottom of your screen to ask us questions regarding anything discussed or communicate to our speakers. At the end of the presentation, we'll have a brief discussion where questions received will be answered if the presenter does not already answer these questions during the course of the presentation. Please note that you will receive a post-session email that will include a link to the materials presented and for the references used today, as well as a link to a video recording of today's presentation. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services provides continuing education contact hours at no charge to you. Your attendance and participation today are being recorded through your login, so there's no need to put your attendance information in the chat box, though we are pleased that you're all wishing each other a good morning. After the conclusion of today's presentation, you will also receive an email with a link to an evaluation. The survey link will be open for 30 days post-webinar. You must complete the evaluation in order to receive CE credit for your participation. After completing the survey, you will receive your certificate within 2 weeks via email. Late evaluation submissions after 30 days from today will not be accepted. Therefore, continuing education will not be awarded in that case. Make sure you complete your evaluation as soon as possible. If you'd like to complete your evaluation immediately, we will be putting information in the chat box towards the end of the presentation. We are expecting a large attendance for today's session, so your patience is appreciated regarding the continuing education components, as we only have 1 staff member who processes all of our evaluations and certificates. If we experience any technical difficulties today, please stand by while we do our best to resolve them. If the webinar gets interrupted in any way, we will get logged back in as quickly as possible. However, if we are unable to get logged back in due to extended technical difficulties, you will receive an email with information about what options will be available to you at that time. Today's training will be divided into 2 parts. In the first section, we will be looking at the role of trauma in various forms and its role in the development of mental health and substance use disorders. Our first speaker, Karolynn Beasley, has a bachelor's in social work from the University of Tennessee, where she graduated summa cum laude and received a master's degree in social work. She is a licensed master social worker and has skills in cognitive processing therapy, internal family systems theory, motivational interviewing, psychodynamic psychotherapy, and cognitive behavioral therapy. She has been with Cornerstone of Recovery, a Bradford Health Services program, for 2 years, working within the residential women's program. In her current role as therapist, she runs process groups, conducts individual and family therapy sessions, and leads the cognitive processing therapy trauma group for the women's program at Cornerstone of Recovery, located in Louisville, Tennessee. In section 2, We will be discussing the concept of grief and we'll explore in greater depth the management of loss. Our speaker, Anna Beatty, Beatty, has a bachelor's in philosophy from the University of Chicago and a master's in creative writing and social work from the University of Alabama. She is a licensed master's social worker. She is certified in EMDR and is a specialist in grief recovery method. She has been with Bradford for nearly 2 years, and she runs the Grief Specialty Group, an intensive closed format group focused on grief that includes process groups, individual and family therapy sessions, and guided informational content about the process of managing grief at Bradford Health Services Warrior, Alabama Lodge location in Warrior, Alabama. Please enjoy today's presentation, and I will now turn it over to our first speaker.
Awesome. I hope everyone can see me. No technical difficulties, hopefully, even this early. Awesome. I hope everyone's well this morning. Good morning to everyone. I'm Karolynn. I'll be your first speaker of the day. I appreciate all of you taking time out of your day to be here with us to discuss trauma and grief among our populations with co-occurring substance use disorders. I want to take a minute before I get us started with content to give an introduction into a little bit about my clinical work at Cornerstone. So like Zach mentioned, I'm an LMSW and actively working on my LCSW supervision. I've had the privilege of having some great mentors in the field, and combined with working at the inpatient level of care, I have been a therapist for the women's program for about 2 years now. Excuse me, I'm having some glitch on my end. Sorry about that. Working in the inpatient setting, you get exposure to trauma really quickly. And working in the inpatient setting in general, you see an anomaly of things present pretty early on. I got some training in CPT within my first few weeks at Cornerstone, and I felt really connected to this trauma treatment method, which has been really instrumental in my career. I had the opportunity to have some knowledge about this intervention through my grad program, but have had the experience in leading the Women's CPT group for 2 years now. And this group has shown some excellent results over time and confirms for me time and time again the importance of incorporating trauma work into treatment programs, no matter what level of care. I developed an interest in trauma treatment while I was in graduate school as well, but over time I felt more and more connected to the work. I want to acknowledge that a lot of the content in this presentation today is heavy material. And so I encourage you to be mindful of any wounds that may surface for you personally throughout this presentation, and to take some inventory of what your wounds may be. Maybe some things surface for you that you haven't thought about in a while, or maybe you thought might not be as present for you, but it has, and it's surfaced for you today. Just take some inventory of that and be mindful of that, and be kind to yourself throughout this process. So I've divided our presentation, the first half of our presentation, into 3 sections to highlight the agenda for each session. In our first section, we will discuss and define trauma. We will review examples of various forms of trauma and identify statistics for trauma, outlining the magnitude for individuals battling the impact of trauma. We will recognize how intersectionality impacts risk factors for trauma. We will define adverse childhood experiences and the significance of this research on substance use disorders. We will outline the impact of trauma on coping strategies and recognize the impact of silencing trauma. So to start us off, trauma comes in many different forms, looking different for all individuals. There are traumas that we often hear about, such as physical, sexual, and emotional abuse, that tend to surface often among substance use populations. There are also many other traumas that impact a wide range of individuals that we treat here at Cornerstone. And to begin our discussion on trauma, I thought it would be valuable to first go through some examples that I have personally seen throughout my work at Cornerstone. Firstly, we can acknowledge that medical issues can be a trauma. For example, the shame in an older adult male that no longer can provide for his family due to disability and injury at work. There can be grief and loss, such as the death of a loved one, especially a child or primary caregiver, close friend or relative, which Anna, of course, will speak more about later on. Within our substance use populations, there can also be some grief in the loss of substances as a primary coping method. I think for a lot of people, the first time they set down substances and are vulnerable enough to go through the detoxification process, they're certainly in a vulnerable spot in a way that can feel like grieving the loss of what they've known for a long time. And when our patients are faced with the trauma of the emotions that perhaps they've never felt before, or perhaps the traumatic imagery is amplified now that they don't have that primary coping method, this facing of emotions is something maybe they've never even felt before, or perhaps mourning the loss of something that soothed the pain for even in a short term. Most individuals in their lifetime will experience trauma. That's an important note here. I believe it's nearly impossible in this lifetime to not experience some form of trauma. When we look at the disease model of addiction, it's imperative that we acknowledge how trauma can greatly impact a person's ability to function, the ability to work and to love. The better we can identify and empathize with our life events that occur for our patients and the way that they've impacted others, the better we can help serve our populations here. We want to be able to start with the experience of survival that has often been long-winded for our patients and allow them the space to thrive rather than just survive. Certainly, lots of our patients have certainly just been surviving or hardly surviving for a long period of time. Approximately 40% of American children will have at least one potentially traumatizing experience by the age of 18. This includes the death of a parent or sibling, ongoing physical abuse and or neglect, sexual abuse, or the experience of a serious accident, natural disaster, or domestic violence. In one large survey, about 1 in 8 children under the age of 17 reported some form of serious maltreatment by adults within the past year. And about 27% of women and 16% of men reported an adult having been sexually victimized during childhood. Having reported an adult sexually victimizing them in childhood. It's important to take into account the impact of intersectionality on these rates and statistics as well. Intersectionality is the interconnected nature of social categorizations such as race, class, and gender as they apply to a given individual or group. And this is regarded as creating an overlapping and interdependent system of discrimination and disadvantage. This is important to reflect on when working with various populations so that we can acknowledge the adversity that others experience. Approximately 1 in 10 children will experience sexual abuse before the age of 18. And this is just the statistic of what's been reported, right? We have to take that into account. So when we look at these statistics, we should keep in mind limitations to the research, such as violence towards marginalized groups appearing to impact reporting, along with there being stigmatizations for certain marginalized groups that can impact their willingness to speak up. Likely these numbers are higher than reflected due to this. And within my work at Cornerstone, there have been times where out of my caseload, every single one of my patients has endorsed history of sexual abuse or domestic violence. And I've actually had groups where it was 100% rate of both. So that's certainly just large numbers that are astounding. Some of the things we think that aren't as pervasive as they are, I have noticed certainly can be. While these numbers can appear shocking, this becomes more and more prevalent each day. As I said, it additionally stands out to me that when people are at the place in their lives where their addictions have become unmanageable and they're willing to seek treatment, they often are opening up about traumas for potentially the first time in their lives. This is why it's important that no matter what our role among the system of treating substance use disorders, I want us to really comprehend the magnitude of opportunity we have to show up for someone in a way that maybe they never have experienced before. So this is a really important point here, that perhaps someone is sharing with you or a colleague a trauma that they've never even said out loud to themselves before. So open-mindedness and empathy can go a long way when someone is willing to share such an intimate detail of their lives. That vulnerability is huge, and I want us to take a second to really sit with the magnitude of that and the opportunity that we truly have when someone shares something as painful and powerful with us, such as trauma. Providing others a safe place when they share trauma is possibly the most important part of the intervention, because it has the potential to help heal deep wounds. It should be noted that trauma can happen at any point throughout the lifespan, whether it be an infant's inability to be held as it cries throughout the night, a traumatic brain injury at the age of 4, molestation by a neighbor at the age of 11, domestic violence with a first partner in adolescence, being sex trafficked at the age of 16, being raped at the age of 21, suffering divorce and mistrust at 25, or witnessing a person's death in your 50s as working on the railroad. These are all intense circumstances that can impact epigenetic functioning. Unfortunately, all of these examples are true examples from my work at Cornerstone, and trauma can be impactful no matter when it occurs throughout the lifespan. However, childhood development can be greatly impacted by trauma as the brain is growing, right? That neuroplasticity. We learn through our environment, and it is how we make sense of the world. So we first begin our trauma presentation in acknowledging how trauma can be impactful within childhood, and discuss an introduction into adverse childhood experiences and how they are applicable to co-occurring substance use disorders. Adverse childhood experiences, also known as ACEs, are being utilized to identify trauma and its effects on neurodevelopment, and this started in the late 1990s. The study by Center for Disease Control and Kaiser Permanente assessed the relationship between adult health risk behaviors and childhood abuse and household dysfunction. This study held a large sample size with follow-up sample positively impacting efficacy for the research. The ACEs questionnaire featured 10 traumas that participants could answer yes or no to. An ACE score can be between 1 and 10 based upon the original study, and the number of yeses reflects an individual's ACE score. So here you'll see the 10 different layouts, the layout of the 10 different elements included on the original ACEs study. So physical abuse by a parent, emotional abuse by a parent, sexual abuse by anyone, growing up with an alcohol and or substance use dependent adult in the household, experiencing the incarceration of a household member, living with a family member experiencing mental illness, domestic violence, loss of a parent, emotional neglect, physical neglect. So these are the 10 different items listed. And findings of the ACEs study showed that people who experience 4 or more adverse childhood events, so if they had a 4 or more ACE score, they would answer yes to 4 out of 10 of these. And the people that did answer with 4 or more ACEs had an increased risk of smoking, alcoholism and drug abuse, increased risk for depression and suicide attempts, poor self-rated health, 50 or more sexual partners, greater likelihood of sexually transmitted disease, challenges with physical inactivity and severe obesity, homelessness, impaired job functioning, and criminal justice involvement. So this research is relevant for many reasons when working with substance use populations. Based upon the findings, you can probably already start to see the connection between some of the impacts of ACEs on our populations. Higher rates of depression and substance use can place someone at great risk for suicidality, which is always important for us to be monitoring in our work. In fact, suicide is a leading cause of death for those with substance use disorders. Childhood traumas can greatly impact a person's ability to cope and to attach in healthy ways. For many, substance use appears to be a temporary resolution for great and disturbing emotional or physical pain that turns into chemical dependency. We can also acknowledge that the connection between mind and body when addressing ACEs. Trauma and toxic stress can greatly impact our body's ability to cope with things, and with one common correlation being gut health for trauma survivors. We're now looking at in the community how gastrointestinal issues and indicators for childhood sexual abuse, indicators for other adverse childhood experiences because of the link between gut health. So that's being further researched. And they're also doing research on probiotic and prebiotic use for gut health, as there is correlations between what the gut health looks like and the microbiome for trauma survivors and for certain mental health diagnostics. Sometimes physical health issues can lead to chronic pain that can also liaison into chemical dependency. So there are many ways that ACEs should be incorporated into the treatment of adults with substance use disorders, because we can better acknowledge the deep-rooted issues at play for many of our patients. For research to indicate the correlation between trauma and addiction, this would indicate further necessity for trauma-informed care and targeting root issues of trauma in our patients in early recovery. This work also highlights an important point that I wanted to make today, which is resiliency is not innate for children. I think this was something that people often said, right? Children are resilient. I know I've heard that many, many times in my lifetime. But I want us to consider that children are actually at great risk, unfortunately, because they are like sponges. And rather than resiliency being something that we consider to be innate, I would ask that we start to consider it, we consider resiliency to be taught rather than innate. So that's something to keep in mind. Now that we've outlined some examples of traumas and how childhood traumas can impact functioning, we can now outline the impacts of trauma into adulthood and how traumas in adulthood can drastically impact the ability to cope effectively. Trauma examples provided in the beginning of this PowerPoint can apply to any time within the life cycle. Experiencing trauma, whether it be an adverse childhood experience or active military combat, can have great and lasting impacts over time. Substance use is one of the many ways we see people attempt to maladaptively cope with trauma. For many trauma survivors, substance use acts as a way to cope with intense and powerful emotions. For other trauma survivors, substance use is utilized as a tool to help feel something throughout the dissociation and the numbness. There are often parts of trauma survivors that seek to escape these deep wounded experiences of pain that can result in suicidal ideations or self-harm. Sometimes other addictions can surface through an attempt to distract or to avoid unwanted symptoms and dysregulation, such as sex, gambling, or pornography. There can also be great struggle with attachment regulation or issues of codependency. These patterns of severed relationships can impede on ability to form meaningful connection or long-term partnerships that can lead to further feelings of loneliness, isolation, or defectiveness. As mentioned previously, there's so much bravery that comes with sharing trauma with another person. In working with trauma survivors, there appears to be a pattern of silencing trauma, and this often becomes a secondary trauma that only amplifies a person's emotional reactivity to the traumatic event. The silencing of trauma or dismissal of trauma can cause lasting impacts on trust and generations of abuse. One thing that seems to come up often is patients being told to get over it in response to time passing following a trauma. One thing we also hear is time will heal. This is a common response to trauma that does not always hold true for our individuals and the human beings sitting before us. Healing is not linear, and to suggest that time will heal can't be the ultimate ease in healing the actual wound. And often this proves to be untrue in numerous traumas. Outright invalidation can often make survivors continue to remain in early stages of trauma rather than being able to move forward toward their healing. Invalidation can look like minimization for trauma experience or comparing trauma experiences. Invalidation furthers cognitive distortions at times, especially when thinking of distorted sense of self-blame. We see this often in cases for sexual assault in the CPT group for the women's program. Lack of social support or having safe adults, friends, or family is certainly another impactful element of a person's ability to cope with trauma. If someone does not know safe space or safe person to share their trauma, they are often keeping trauma held in for years, only to be battling these emotional wounds for years in silent turmoil. Another pattern I see in my work is a common fear of not being believed. Many trauma survivors continue to remain silent due to fear of not being believed. And so in our work, we must be sure to provide a listening ear, an empathetic approach, and a supportive engagement. If you are new to being in the treatment environment and feel that you are not sure how to respond when someone opens up to you about their trauma, just to provide some good tangible examples of how to respond to that if you feel at a loss for words. A great therapeutic and empathetic response can look like, I'm not really sure what to say right now, but I want you to know that you're safe in this moment and I hear you. I care about your traumatic experience. So now we've reached the second section of our trauma portion where we will discuss the impact of trauma on substance use disorders. We will identify PTSD criteria, recognize patterns of post-trauma response in our patients, and define the 4 common trauma responses. Excuse me. I hope everyone can hear me okay. I see some hands raised in the chat and we'll take questions afterwards. Okay. Thank you for your interest. So to begin our second section, when trauma occurs, we often go innate into our trauma responses of fight, flight, freeze, or fawn, activated by the reptile part of our brain. When we go into trauma response mode, certain parts of our brain function decrease and other portions increase. A surge of cortisol and adrenaline become increased in order for the body to take physical response to remain safe in the presence of a threat. After the presence of a threat occurs, the nervous system should be able to become restorative. However, PTSD can interject our ability to feel safe and to cause a heightened and continuous stress response. This causes difficulty in returning back to restorative mode. And this is where we start to see PTSD symptoms show up for our patients, where we can begin to assess for criteria. These symptoms show up in the brain on a physical level as the brain is adapting to the world around it, and that has relayed a message of, I am unsafe. There are parts of the brain that generally become impacted when we think of PTSD symptoms. The amygdala is the area of the brain that scans for threats and connects memories and emotions. After trauma, it becomes more active and sensitive. It can become highly alert when it detects threats, and small indicators of threats can cause high levels of reactivity, such as even a smell or a sound that reminds you of the traumatic event. Or perhaps becoming startled rather easily with sudden movements of another person. Brain scans also indicate that the hippocampal volume can decrease following trauma. This is the part of the brain that processes emotions and memories following a traumatic event. And this can cause struggle with emotional processing and struggle with distinguishing between what is past and what is present, what's happening in the here and now versus what's happened in the past. This is where we see symptomology of flashbacks show up, the experience of a memory that feels as though you are being immersed back into the trauma, as if it was happening in real time. During these flashbacks, the amygdala becomes reactive and becomes reactivated and sets off the recycling of distress response. This relationship between the hippocampus and the amygdala essentially deepens the fear response over time. The prefrontal cortex that controls higher level thinking shrinks. This is an important part of the brain, and it becomes disrupted due to reverting back into that reptilian part of the brain, right? We go into that instinctive mode. Due to repetitive nature of the higher level thinking becoming turned down, the more we use the part of the brain or any part of the brain, the more the pathways grow. And the less we use a part of our brain, this area becomes trimmed within pathways according to neuroplasticity. This shrinking of the prefrontal cortex can then cause struggle of thinking rationally and clearly of the trauma, being able to speak of the trauma, and being able to decompress from the trauma. While many are familiar with the term stress response, it's important to highlight up-to-date information on various stress responses. Often we reference fight or flight mode, but we can sometimes leave out two other identified trauma responses of fawn and freeze. Starting with fight, this is when the stress response activates fight mode and allows for self to become combative. Challenging, defensive, or physically reactive to the traumatic experience or event. An example of this would be physically fighting back during threatening experience or to amplify verbally during emotional abuse. The flight response, our second response, is to abruptly remove self from the traumatic experience. An example of this would be running away during attempted kidnapping. The freeze response, the third response we'll go through, is a response to become shut down and to be unable to make decision, to remain frozen during a traumatic experience. An example of this would be, unfortunately, something that we're seeing a lot in the media right now, where children will play dead during an active shooting. Fawn response is to make self smaller in presence of a threat or attempting to win over an abuser during a traumatic experience. I'm really glad it feels like we're talking about this more in media. And this is an important one that you'll see often within patient populations. And an example of this would be to constantly respond in agreement and compliance with a verbally abusive boss, often showing body language, sitting within self, radically compliant with those that have abusive behavior towards them. And to go beyond just highlighting traumatic events that can correspond with each behavior, we can acknowledge the impact that can be compounded for trauma survivors, and numerous traumas can add on to stress response activation. These stress responses can show in day-to-day behaviors at times, surfacing from previous experiences and ways we react to various scenarios. So for example, when someone with overactive fight response that survived years of domestic violence, they may present alert and can often appear defensive or tough as they become threatened. They will protect themselves at any cost. And this could lead to outbursts as they are often related to previous experiences rather than the here and now, and being able to understand what is going on currently and emotionally for me. This can then lead to feelings of shame and remorseful post-outbursts. Someone battling reactive flight response might struggle with might struggle with always acting in a rush or feeling as though they might be avoidant or leave emotionally distressing situations. This could be avoidance of sitting still or feeling trapped easily. Someone acting in overactive freeze mode may struggle with inability to make decision or disengage and withdraw fully during times of conflict, almost presenting as the silent treatment. And finally, someone acting in overactive fawn response may struggle with fear of saying no and excessive people pleasing, or possibly struggling with emotional monitoring of others to continue to intake information regarding the possible presence of conflict or lack of approval. While trauma responses are often spoken of during the presence of a major trauma, it should be noted that we use these neural pathways relevant to neuroplasticity, as I've referenced a few times. So at times we could see in our patients the reflection of trauma response when there is a conflict present throughout the course of treatment. Perhaps these trauma responses could even be triggered and be a source of pain that could indicate relapse. For example, when we discuss overactive fight response, I'll give this scenario. A patient in an IOP program during a conflict in group has an anger outburst rather than being able to engage in effective trauma resolution due to feeling triggered. After storming out of the group, this patient maybe does not process, but rather internalizes great feelings of shame and ends up going to the liquor store later that day, as he feels there is no other ways with coping of this ability to, that individual might not know how to cope with that feeling of shame after the outburst. And that could be a reason that he or she may have gone and drank, right? It was that true fight response, and then after came flight. And so there would be an example of how we could have the ability as staff to interject that process and to say, hey, what was going on for you during that group? Where was your mind? What were you feeling? What did that look like for you from your perspective? So these are important things to take into account, the way that the past has impacted ability to regulate in the present. I wanted to include PTSD criteria just as a good reminder of what to be looking for within clinical assessments and interviews. So it's important for us to be asking questions regarding symptoms to better understand how trauma is surfacing for our patients. It's always good to revisit diagnostic criteria and to ensure that we are paying attention to how trauma is presenting and impacting someone's ability to cope. So to begin, excuse me, got to start with criteria A. So criteria A, the stressor. This is required for the diagnostic criteria. So a person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following ways: direct exposure, witnessing the trauma, learning that a relative or close friend was exposed to a trauma, indirect exposure to adverse details of the trauma, usually in the course of professional duties. So this is where we think about first responders, medics, EMTs. Intrusion symptoms, and one of these is required. The traumatic event is persistently re-experienced in the following ways: unwanted, upsetting memories, nightmares, flashbacks, emotional distress after exposure to traumatic reminders, and physical reactivity after exposure to trauma reminders. Avoidance for criteria C. Avoidance of trauma-related stimuli after the trauma in the following ways: trauma-related thoughts or feelings, trauma-related external reminders. So that's where you'll see that emotional blocking, not being willing to talk about it, that pervasive avoidance that can really surface for a lot of our survivors. Criteria D, negative alterations in cognitions and mood, and 2 of these are required. Negative thoughts or feelings that began or worsened after the trauma in the following ways: inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself or the world, exaggerated blame of self or others for causing the trauma, negative affect, decreased interest in activities, feeling isolated, difficulty experiencing positive affect. Criterion E, alterations in arousal and reactivity. Trauma-related arousal and reactivity that began or worsened after the trauma in the following ways: irritability or aggression, risky or destructive behavior, hypervigilance, heightened startle reaction, difficulty concentrating, and difficulty sleeping. And then here I also added in the dissociative specifications. So in addition to meeting criteria for diagnosis, an individual experiencing high levels of either of the following in reaction to the trauma-related stimuli: depersonalization, experience of being on an outside observer or detached from oneself. So one example I will usually review with the patients when I'm kind of screening for this is, do you feel like you're an audience member and your life is the movie or your life is the play? And if they say, oh my gosh, yes, I feel like this all the time, to me, this would be an indicator of depersonalization. And watching affect when this dissociative nature is really important, whether you're in the group or individual therapy setting. Derealization, the experience of unreality, distance, or distortion. So things are not real, almost as if the earth is happening around you or life is happening around you. Delayed specification. Full diagnostic criteria are not met until at least 6 months after the trauma, although onset of symptoms may occur immediately. So it's important to take into account for PTSD diagnosis that symptoms must be lasting longer than 30 days. Anything shorter than 30 days would indicate wanting to look at acute stress disorder diagnosis. These symptoms create distress on social, occupational, or life functioning. These symptoms are not due to another illness, medication, or substance use. So we wouldn't perhaps go right into a provisional PTSD diagnosis if someone was actively in medical stabilization. And so for this reason, you'd want to ensure that someone is stabilized and detoxed effectively before you really start screening for some of these things, in my clinical opinion, because of that last piece of information, right? These symptoms are not due to an illness, medication, or substance use. All right, trauma-informed care. So as we've reviewed what trauma is, stress responses, and how trauma impacts the brain, we can use this information to better care for our patients with substance use disorders. Utilizing a trauma-informed care approach can allow for person-centered work, where we are able to recognize the human being sitting before us and work to reach an empathetic understanding of the role that substance use has played in coping with great emotional pain. While substance use disorders are maladaptive, we can work to get to the root of the substance use disorder when we come from a trauma-informed approach. We have the opportunity to not judge the behavior, but to recognize it and to help the patient become curious about their own patterns to reach that self-awareness and that healing. This is where we are able to branch beyond being trauma-informed and also start to work toward being trauma-sensitive. When we are able to look at the human before us and acknowledge them, not just as a patient, but as a human, and provide a warm and non-judgmental stance, we have the opportunity to build rapport and help them understand how we are safe in this environment. Sometimes subtle things we can do in our practice help show a patient that we are a safe person. One time I was facilitating a group with one of my colleagues at the time, who is also one of my good friends. And that was quite a privilege to do for a while. We noticed that following CPT group, one of the patients was more activated than usual for her, because we had experience with her for a while. She, like I said, she had that higher level of activation than usual that we were used to for her baseline. And upon discussion with her and noting her fundamental needs, we offered her a snack and some water, and this alone was able to improve some anxiety for her because she hadn't eaten that day before CPT group, and it's certainly such a difficult group with hard content. And so come to find out, she was hungry and thirsty, which amplified her trauma response and her body's ability to cope because she didn't have her fundamental needs met. So even small things like that are important, because you could tell how much it meant to her that we were even thinking about her fundamental needs in a way that primary caregivers had not before. So sometimes even what feels like a little action or a little question can go a really long way for working with our patients. Within the final section of the trauma portion, we will identify effective trauma therapy methods, discuss the importance of length of stay and treatment and trauma methodology, and understand the importance of continuing trauma therapy in the step-down approach to substance use treatment. Our last section for the trauma portion. Okay, so when selecting a trauma therapy method during substance use treatment, it's really important to take into account how long your work will be with the patient. I cannot stress this enough. We do not want to put a patient in a situation where they are overactivated in a way that we will not be able to contain as they progress throughout the course of treatment. For example, if you work in the outpatient setting where you are able to see a patient weekly or even multiple times weekly, EMDR could be a wonderful and effective method. However, if you are in the residential setting, averaging between 28 and 35 days of treatment, you may have to utilize internal family systems theory or CPT to navigate trauma in a way that can be most safe for the patient. In addition to length of stay, it's important to continue to be noticing of therapeutic rapport and being able to work on the establishment of a safe and open environment with the patient prior to really starting that trauma treatment. Be willing to meet with the patient where they are in their trauma journey, right? Meet them where they're at. We also want to take into account access to continuing care and reflect the importance of continuing trauma work for our patients that do meet criteria for PTSD, or perhaps those that are subclinical, but are struggling with ongoing grief and loss or acute trauma symptoms. We want to be sure that aftercare planning is being monitored so that we are setting the patient up for success in their therapeutic journey, right? We need to take into account, what does the aftercare plan look like? What is their financial resources? What is the true access to their care? Cognitive processing therapy is one of our primary methods of trauma treatment that we offer at Cornerstone. I run this treatment method in the group setting for the women's program, and we meet 3 times weekly. CPT is a great method for trauma treatment that can fit within the residential model of treatment if a patient is within at least 28 days of stay. CPT is different from other trauma treatment methods in the way that it has the patient focus, not as much on the narrative or the what, and more so focuses on the post-trauma cognitions of why a person believes this trauma occurred. This cognitive method can show great efficacy within a full stay in our program. There is an overall focus on Socratic dialogue and utilizing open-ended questions related to self-esteem, power and control, intimacy, trust, interpersonal relationships, and self and worldview. So through this dialogue, patients engage in identification of cognitive distortions, which the intervention technique calls stuck points. And these are cognitive distortions that are keeping the patients immersed within the trauma. So through utilizing challenging questions and working on building cognitive skills in challenging one's thoughts, patients become able to distinguish what the narrative they were telling themselves was versus what is the factual evidence of the event. I have seen great improvements in sense of self-blame, self-esteem, and trust through using this method. It's really awesome when patients will tell me that pre-group, when we ask those questions for assessment and evaluation, I might say, what, on a scale of 1 to 100%, how much did you believe that this sexual assault was your fault prior to attending this group? And it is really miraculous when they report pre-group that they believe it 95, 90, 100%. And then after the completion of CPT, they believe it 5% or sometimes even 0%. And that's just a beautiful moment to be witnessing with patients. I can't even express that enough. The CPT method utilizes a workbook that patients engage in completing one assessment at a time. I personally have each patient work on one assignment at a time to prevent emotional flooding, especially with the first assignment being an impact statement. This assignment has a patient go through what this trauma made them believe about themselves, about the world, and incorporating thoughts surrounding those 5 domains, as I mentioned: the self-esteem, power, control, intimacy, and trust. This impact statement and verbal processing in group that incorporates Socratic dialogue allows for the patient to hear their cognitive distortions out loud and work to challenge them. Once the distortions or stuck points are identified, they can then begin working on the ABC worksheet and challenging questions worksheet after that. I have noticed that as patients progress throughout this work, they often are able to see and hear their own progress, which is really exciting. Peers often will even point out one another's progress as well, which is what is really exciting about the group dynamic for this skill. It's equally as exciting as individual, and of course it looks different, but it is really cool when peers are able to really connect with what a stuck point is and point that out for one another and to challenge one another's thinking in a way that's supportive and empathetic. This method leaves patients with skills also. That's an important thing to highlight about this intervention that I really love. When patients leave treatment and they've completed the CPT group, they leave with tangible skills to continue to identify patterns of problematic thinking, and challenging intrusive distortions. Another method that I really enjoy is internal family systems theory, otherwise known as IFS. This is another great trauma therapy method for our populations. IFS is a non-pathologizing approach in a way that works to treat the entirety of the human. This theory outlines that all individuals are comprised of parts. These parts have their own ideals of the world, personalities, and thought structures. these parts can operate as protectors, firefighters, or exiles. And sometimes we will hear people using language like, I'm not sure there's this part of me that feels like this, but then there is another part of me that feels like this. This language can reflect IFS theory, which would indicate that there are two different parts coming forward with different emotions and thoughts surrounding the event. While all people are comprised of various parts, there is also the core of the individual, which the theoretical framework would identify as true self or self. When someone is acting in their true self, this is a reflection of their essence or their spirit, as I like to say. The individual is most centered and reflective of calmness, compassion, curiosity. So this approach to trauma treatment method appears to be beneficial for building self-awareness, recognizing patterns of maladaptive behaviors, and building absence of judgment for self and for others. Accelerated resolution therapy, or ART, is a great and rather quick approach to trauma treatment. So this technique allows for targeting traumatic imagery and to decrease this intrusive imagery, nightmares, flashbacks, and disturbing images to decrease activation. ART therapists will guide the client to replace the negative images in the mind that cause the symptoms of post-trauma stress with positive images of the client's choosing, which is pretty cool. So I call this trauma treatment method EMDR's baby cousin, because it seems to utilize similar ideals and approach, but seems to work for individual care where you know you have limited time with patients. So this is a really good alternative. Within the ART protocol, the IVE movements, along with other ART enhancements, make these therapies work much faster and more effectively. So one of the special aspects of ART is that when clients replace their negative images with positive ones, they don't need to talk to the therapist about any details of the actual trauma. This is because ART is procedural and though creative, and the client is really in control of the process while the ART therapist is a helpful guide. This makes the therapy easier on the client and easier on the therapist. Disclaimer, I am not an ART therapist and have far more experience with IFS and CPT. However, I wanted to include this because, to as transparent as possible, I'm working on getting my ART training within this upcoming year because of the evidence-based approach being an ideal treatment at the level of care I work in. There are many other forms of trauma treatment that I didn't even include in this PowerPoint, such as EMDR, which I've referenced a few times, and that has large name recognition in our field due to the overwhelming evidence and supporting efficacy. And AAIT is another one that I didn't include in the PowerPoint, but that method is really awesome. It's very tried and true. However, it's not yet really established in the community because it's currently working on building its research, so that we can reference it as evidence-based. Obviously, our field likes to have a lot of research behind the trauma treatment methods that we choose. So AAIT is currently building its research foundation, which is wonderful news. And while there are many other forms of trauma treatment out there, for example, one trauma treatment method that we use a lot in our programming at Cornerstone is schema therapy, which is pretty awesome. I've seen some really cool things work from that. There's 18 different schemas formed throughout childhood, and we use those in reference to patterns of problematic behavior that can really correspond with deep wounds and trauma as well. So there's lots of other forms of trauma treatment out there. I don't want y'all to think that just because I included and highlighted these three today, that this is the limiting thing that I swear by. There's certainly lots of different things that work for lots of different practitioners and for patients. But I felt like it was great to highlight these three because, you know, ART isn't as popular as some other others, and neither is AIT or CPT. I think some of these you know, are just really working on building further foundation in the field. So it's exciting to see that work come forward. So while there's lots of trauma treatment methods out there, I found these three to be appealing and effective in my own personal experience and what works for me as a person who is working on trauma treatment within approximately a 30-day program. Sometimes our patients get 28 days, sometimes they get 21, sometimes they get 40, but it's a rather short treatment stay. So I have to be mindful of that when selecting my interventions. There are other skills I utilize on a daily basis, like guided imagery, imaginal conversation, and CBT-based exercises. But again, I felt that these three were really important to highlight due to their efficacy. While I placed some recommended readings on the slides along with references, I want us to take a few minutes before we move to our second portion of things to engage in a few minutes of mindfulness. We have discussed a lot of material up until this point and want to guide us in some breath work to allow for decompression from the material. So I'm gonna ask everyone to be kind to themselves in this moment and to engage in 2 minutes of self-care with me if you all would be willing to have me guide you in a mindfulness. So if everyone could, to their comfort level, close their eyes and get in a comfortable position. Just take a moment, get in a position that feels comfortable for you and close your eyes. And I'm going to count us in on some breath work to just allow for some moments of self-care. We're going to be breathing in through our nose and out through our mouth, breathing in for 2, holding for 2, and breathing out for 2. Beginning on my count. In and out. 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 One last breath in and out. I want you to open your eyes whenever you feel ready, if your eyes are closed. Shake out any lingering sensations of your mind or body and move with kindness in your heart today. I know my nervousness from this presentation already feels decompressed from doing that, and I hope you have that similar experience as well. Again, move with kindness in your heart today, and thank you so much for allowing me to be with you today, and I acknowledge the time that you all took out of your Friday to be here with us, and I greatly appreciate you all trusting me with that. So I hope you all took something from my portion today. I appreciate you. So now I'm going to go ahead and turn things over to Anna so she can share about grief and addiction. Thank you.
Thank you for that. And I'm going to disrupt a little bit. We're going to take a short break at the request of some of our audience members. We're going to take about a 5-minute pause. In Central Time right now, it is almost 10 o'clock. Let's come back at 10:05. Give you a chance to stretch your legs right after that meditation exercise. I agree with Karolynn, feeling much more relaxed and centered right now. So let's enjoy that for just a few minutes before it passes and we get back to our next presentation. Okay, 5 minutes. We'll see you back. Thank you. Welcome back, everyone. It is 10:05 Central Time, 11:05 if you're Eastern, and if you're not in one of those time zones, I don't know how to do math. So welcome back. We are going to be starting back with our second part of our session, which will be focused on grief and addiction. Our speaker, Anna Beatty, keep mispronouncing her name, excuse me, will be taking over for that portion. And please keep those questions coming in the chat and in the Q&A. Appreciate those we've received so far. We will make sure we can circle back to those at the end. Turning over to our second speaker now.
Thanks, Zach. All right, hi guys. All right, so thank you, Karolynn, for your presentation. That was super informative and wonderful, so thank you for that. So yeah, hi all, I'm Anna. I'm also an LMSW, and I work as a counselor at the Extended Care Program, ECP, at Bradford in Warrior, Alabama. So ECP is a bit longer. It's an 8 to 12 week program, right? And within ECP, we have a healthcare professionals program that focuses on treatment for healthcare professionals such as doctors, surgeons, dentists, nurses who have substance use disorders, right? And we also get a fair number of lawyers with addiction issues. So these professional populations have high rates of alcoholism and also high rates of complicated grief, right? They're also two really put together populations. And this is going to be relevant, as you'll see, right? So they're folks who look like they have their lives together on the outside, but oftentimes are struggling on the inside. So at Bradford, I lead the grief specialty group. The grief group is a closed group, so we're capped at 6 people, and each round runs for 3 consecutive Tuesdays. At the grief specialty group, we use the grief recovery method, which was developed in the 1970s and is an evidence-based program. So the grief recovery method was originally designed as a 10-week program, and I've morphed these 10 weeks into 3 full intensive days, right? So we start at 9:15, and it's not uncommon for us to run up till 4:45. The method's also action-based, right? So it involves a sequence of writing and listening activities. I like it a lot because in that way, it sort of mimics AA, right? Like AA, the grief recovery method is designed to be a program of action. As they say, you know, we don't necessarily think of recovery and grief as 2 words that go hand in hand, but they do it somehow. And I think it's quite effective. Okay, so the sources I'm going to be working from today is Worden's Grief Counseling and Grief Therapy. So William Worden is a psychologist whose work focused on grief and what grief looks like. He created a framework, the 4 tasks of mourning, which conceptualizes how people mourn and how we as clinicians can help folks move through their grief, right? And his work is what I'll be referencing throughout the first half of the presentation. Second, the Grief Recovery Handbook. So this is the book I used in the grief recovery group at Bradford. And I've included a few of their exercises and suggestions in my presentation. If you take to it, you're able to become a grief recovery specialist online. I am, and I recommend it. I think they're great. And then finally, Grief and Addiction by Julia Bates-Mave. So Julia Bates-Mave is a professor at the University of Wisconsin-Stout. Her book came out recently in 2021, and it looks at different theories of grief and mourning, and then maps these theories out onto addiction recovery. So it's a very interesting read, and I encourage it for anyone working in the addiction recovery field. It gave me a lot of new insight. I'm sorry. I've got to go back for a second. I skipped ahead. So anyway, before I go back any further, I want to give you all some quick definitions. So first, grief. What is grief? Grief is the experience of loss of loved one to death, right? But more expansive definitions say that grief is the experience of loss period, right? And also mourning. So later on, I'm going to be talking about mourning. While grief is the experience of loss, mourning are the actions and behaviors involved in moving through that loss. So grief is a feeling, mourning is a process. So when Zach first approached me about this talk, he asked if I could speak on grief and addiction, which got me thinking, what is the relationship between grief and addiction? So what I see is that there are at least three ways to consider the relationship. One, we can say that substance use creates grief, right? Second, we can say that grief may lead to substance abuse. And third, we can say that addiction and grief go hand in hand. Basically, all addictions contain grief, and addiction recovery, particularly those early stages of addiction recovery, is grief. It's the experience of loss of a loved one, which is one's drug of choice. For my presentation outline, so I'm going to touch briefly on this first idea, that addiction creates grief, before spending the bulk of the presentation exploring the latter two ideas. I'll be looking closely at what grief, as an experience of loss of loved one to death, looks and feels like, and to help us understand how, when complications in the process of grieving arise, these complications put us at risk for a substance use disorder. And finally, I will be looking at how addiction recovery, particularly those early stages of addiction recovery, is a grief experience, and how we can better tend to our clients if we validate the grief that's involved in the loss of one's addiction. Throughout the presentation, I'll incorporate a lot of concrete suggestions and provide exercises for how we clinicians can help our clients, both those clients who are grieving the loss of a loved one to death and those who are grieving the loss of their addiction. Okay, next up, we went through this. These are my sources. Warden for the first half, grief and addiction for the second half, and I'm going to be sprinkling basically the grief recovery method throughout. So, okay, so what do y'all see when you look at this cartoon of Uncle Sam drowning in pills? What I see is grief, a whole lot of grief, right? So approximately 110,000 people died of drug overdoses in the US in 2022. For some context, where my home is, in Tuscaloosa, Alabama, there are 100,000 people. So 110,000 deaths is wiping out an entire mid-sized city and then some. It's said that every time someone dies, their death leaves 5 people in grief. So that's a lot of the grief that addiction causes. Many of our communities in the throes of this opioid epidemic have been experiencing collective grief. Collective grief is when a whole community experiences extreme change or loss, right? And it comes with its own sets of risks and complications. The opioid epidemic is creating collective grief, and it's also leading to a form of grief known as stigmatized grief. Stigmatized grief is the term for the grief someone holds for a person who has died a stigmatized death, such as death from a drug overdose. When a death is stigmatized, oftentimes the bereaved will feel shame or secrecy around the death, and as such, they don't believe it acceptable to mourn the death honestly, fully, and openly. So the irony is that when we don't allow ourselves to mourn and to move through that experience of grief, we can get into complications, which then put us at risk for substance abuse. So here's the cycle we're stuck in. Addiction leads to stigmatized grief and collective grief. Stigmatized grief and collective grief can lead to complications in the mourning process, which can lead to complicated grief. And complicated grief puts one at risk for addiction. Whoa, I'm sorry. I've got to. All right. So we've seen how addiction leads to grief, and now I want to look at how grief can lead to addiction. But to understand this, we have to have a thorough understanding of what grief, normal, uncomplicated, regular grief, looks and feels like, right? So for now, I'm only considering that more narrow definition of grief, which is the experience of loss of a loved one to death. First off, grief is individual. The experience of grief will vary from person to person, and there isn't one right way to experience grief. How we experience the loss is going to depend on a variety of factors, such as attachment style, culture, personality type, and of course, our relationship to the loss. Next, grief does not follow stages. So some years ago, Elizabeth Kubler-Ross's work on the stages of death and dying was superimposed onto grief, right? And an unfortunate consequence of this is that many people think that grief is a linear process that follows clear stages. So I love this cartoon on the right. It gets at what these stages really feel like, right? So sometimes a wave of grief hits us and we feel utterly crazy, insane. Then the wave passes, we're good for a while, and that crazy, intense grief wave hits us again unexpectedly and brings us to our knees. And yeah, the symptoms of grief truly can feel and look, quote unquote, crazy. So I'm going to delve into this further, but this is exactly why it is crucial that we counselors recognize the normal, healthy symptoms of grief. So we can educate and reassure our clients, no, you're not going insane. You are experiencing grief, which is normal and healthy. Another thing that it is extremely important that we understand and that we let our clients understand is that grief takes time. And according to the rules of our culture, grief takes a lot of time, like an inappropriate amount of time. Worden suggests that the initial experience of grief takes at least 1 year. That's 1 year of having quite intense, crazy feeling symptoms. And others suggest that grief takes at least 2 years. Frankly, in our society, 1 to 2 years is way too long for a lot of people to be experiencing strong, unpredictable, uncomfortable, and societally inappropriate feelings. So often in my grief group, I hear, I buried my mother on Saturday and I went back to work on Monday. Others might say, oh yeah, I grieved. I cried for about a week, but then, I had to go back to work and I had to take care of my kids. So I don't know, I didn't allow myself to grieve. I just couldn't, right? So the thing is, in the long run, it is unhealthy to suppress our grief and to not allow ourselves those years, that time to grieve, to really experience the loss. Suppressing our grief does not get rid of the grief. It merely leads to complications down the road. So I know that I just said that grief is individual and there isn't a right way to grieve. I would say that there are healthier and unhealthier ways to grieve. And an unhealthier way to grieve is to not engage with that experience of loss. So what are some feelings common in the normal experience of grief? First off, sadness. This one is self-explanatory, right? The thing is, many mourners fear that sadness and fear its intensity and will try to block the sadness. Not healthy. Anger. So anger is one that's important for us to talk about with our grieving clients. Feeling angry towards the person who died, feeling angry that they died, is quite normal. The thing is, a lot of clients feel uncomfortable with their anger because it's not rational. They'll think, why should I feel angry that John died? It's not like he wanted to die. This doesn't make any sense. I shouldn't feel angry, right? And when they feel uncomfortable with that anger, they may attempt to repress it. And in repressing it, they can direct it towards the wrong objects, such as turning the anger inwards towards oneself. Repressing the anger or transferring the anger onto inappropriate objects, such as oneself, can lead to complications in the grief process. And complications can make things worse for our clients. So what can we clinicians do to help our patients be okay with their irrational anger and support them so they don't risk repressing this anger? First off, it's simply to normalize the anger. Remind them that while seemingly irrational, it is totally normal to feel angry at your loved one for dying. Providing some psychoeducation can help in that normalization process. So one helpful way to understand the anger is by thinking about attachment theory. Bowlby has this example. Think about the kid who loses his mom in the department store, right? When the child finally finds their mom, they hit their mom. I'm so mad at you, don't leave me again, right? It's irrational. It's totally irrational. They're scared of losing their mom. So then when the mom comes back, they don't give her a hug. They get mad at her and hit her. What's up with that, right? But all that's happening is that primal fear of losing our attachment. Oh, shoot. Sorry, I'm getting a little handsy with my mouse. That primal fear of losing our attachment is coming out, right? And the fear manifests as anger. Moving on to blame and guilt. So when anger gets repressed, it can often show up as blame or guilt, anger towards oneself. And while a certain amount of this blame and guilt is to be expected, we can also reduce some of the blame and the guilt through reality testing and through examining that initial anger that has been repressed. Notably, grievers who blame the deceased tend to be angrier in the beginning, while grievers who blame themselves have more difficulty accepting the loss in the long run. In other words, while the anger towards the deceased can be more intense and scarier to navigate, in the long run, those who just let out that anger, let out the anger. You're angry that the person you love died. Doesn't make sense, but you are. Those who just let it out tend to have better outcomes. A lot of these other feelings are relatively self-explanatory, so I encourage you to familiarize yourself with them. And I'm going to skip down to emancipation and relief. Emancipation, freedom. If one had a complicated attachment towards the deceased, they may feel emancipated, freed from the deceased. This can be a complicated feeling, as it will go hand in hand with feelings of sadness. As clinicians, again, we can help to normalize and validate the feeling. Relief. Similar to emancipation, sometimes we feel relief after someone's death, especially if they had a long illness or if they completed suicide after several attempts. Guilt can accompany this feeling of relief. As clinicians, again, what we can do is validate and normalize. And finally, numbness. Some folks experience numbness. This can be a protection from a flood of feelings. There's nothing unhealthy about numbness, but if it exists for an abnormally long period of time, it can block the grieving process and lead to complicated grief. All right, so just to reiterate, none of the feelings here are pathological. They're normal and healthy for the first 1 to 2 years after grief. As clinicians, we are responsible for letting our clients know that the feelings they are having are normal and healthy, right? So I want to give y'all a minute to just read through these physical symptoms. If you are having these physical symptoms for up to a year or 2 years, what would you think? Honestly, I'd probably think that I was dying or that there was something seriously wrong with me, physically or mentally. So I want to tell y'all an anecdote. I had a patient who told me this story. 2 decades ago, her father died. Within a year of her death, she started feeling tightness in her chest, depersonalization, that is the sense that the stuff around me isn't real, I'm not real, and an oversensitivity to noise. She thought there must be something seriously wrong with me. So she went to whom she refers to as a doc in the box to get checked out. This doc couldn't find anything physically wrong with her. And without knowing anything about her grief, without knowing that her dad had died recently, he diagnosed her as having anxiety and gave her benzos. She never went to any therapy. She just started taking those benzos to manage her symptoms. 2 decades later, of course, she's in rehab and she's addicted to benzos as well as alcohol. That's a true story, and it's really, in my experience, not an uncommon one. I've had more than one patient who had a family member die, and within a year of their death, started experiencing grief symptoms and were misdiagnosed as having anxiety and prescribed benzos, and then ended up addicted to the benzos as well as other drugs, right? For this reason, I'd say it's super important for us to familiarize ourselves with the physical components of grief, because grief is truly physical and can easily get misdiagnosed if we're not careful. And finally, it's key to have your client be familiar with these physical sensations, because they might be having these strong physical sensations and think, there's something wrong with me, there's something wrong with me, there's something wrong with me, sort of adding another layer. When in truth, no, there's nothing wrong with them. They're just in grief. For cognitions, I want to focus on the last two cognitions here: sense of presence and hallucinations. Sense of presence. The sense that the dead person is still there with them. Hallucinations. The scientific outlook calls this having hallucinations. A spiritual outlook would call this seeing spirits or ghosts. Regardless, it is normal for grievers to see and hear the deceased person. It's especially common for the few weeks after death. Another anecdote. I had a patient whose wife died when he and she were quite young, around age 24. The wife had a sudden and violent death, and afterwards, the patient experienced all of these cognitions on this list, including the sense of presence, right? He began seeing her, and he began talking to her ghost. So this all happened in the weeks following her death. Unfortunately, he wasn't told, hey, you're experiencing a normal grief reaction. You're grieving, you're in grief. You've just lost your wife. What you're doing is normal and okay. Instead, my patient was told that he was having a psychotic break and was diagnosed as having a manic episode and put on hard psychiatric drugs, right? So shortly after he quote unquote recovered from his psychotic break, the man remarried, never having allowed himself to grieve, to just experience the loss, that sadness, all the flood of feelings that came with the loss of his first wife. This young man learned to suppress these emotions through alcohol. And now, years and years later, after the death of his first wife, he's in rehab for alcoholism. All of this is to say, our society is not okay with the intensity of grief. Grief looks scary. It can involve hallucinations, it can involve dissociation, it can involve intense worry. But if we as clinicians can build a culture where when our patient is experiencing these symptoms, this grief, we hold their hand, we walk with them through the grief and say, hey, what you're feeling and thinking is intense and scary, and it is normal and okay. Our clients will be much, much better off. All right, behaviors. So if you go on the internet and you Google, do animals mourn? You can fall down a rabbit hole real fast. Lots of debate about, yes, animals do exhibit signs of grieving and of mourning, or no, they don't. The animals are just confused. We're anthropomorphizing them, and their confusion looks to us, humans, like grief. Here on the left is one of those grieving animal pics. It's a still from a documentary about penguins. You can see there's a mama penguin and her friend comforting her, and at the mama's penguin feet is her dead baby, whom she's refusing to leave. So here's an example where the mama is refusing to leave the baby who's dead for way too long. She's staying with that baby. Is she grieving the baby? Or is she just confused, grieving, confused? My take on this debate of are animals grieving or are they just confused is this. Regardless of whether or not the animals are grieving, the important point is that the behaviors we exhibit when in grief resemble the behaviors of a confused animal. Which, frankly, if you are used to being a very put together, rational human, and you start acting like a confused animal, it can feel super scary, and it can look scary to onlookers. The point again is that the behaviors in grief are very primal, very physical, and often outside of our volition. That continuous sighing or involuntarily calling out the names of our loved ones, even though we know rationally that they are dead, or becoming totally absent-minded and distracted, being unable to sleep, unable to eat. In grief, our body behaves in ways that our rational mind is not comfortable with. But again, the best thing we can do is simply go with it, to allow ourselves to experience the grief by experiencing the behaviors. So going over all these symptoms of grief, you might be thinking to yourself, a lot of these symptoms look like depression. How am I to know what's depression and what's grief? And yes, sometimes the two can resemble each other. So I want to spend this slide talking about the relationship between depression and grief. First, let's look at how grief, when suppressed, can turn into depression. So take a look at this chart on the left. We start with the feelings of grief, which, as we recall, often contain anger towards the person who died. Oftentimes, the anger doesn't feel okay. We talked about this, right? The anger feels inappropriate, and a person may feel guilt and shame for feeling that anger. So what do? They suppress that initial anger that was directed towards the dead person. But that anger doesn't just go away just because it's been suppressed. It morphs into something else. It morphs from anger towards the dead person into anger towards oneself. And that anger towards oneself, which can look like shame and a loss of self-esteem, can then become depression. Again, this graph serves as somewhat of a warning against the repression of emotion. But it can be hard for us clinicians to know when we see our client, how do we know if they're in grief or how do we know if they're in depression? Because the two can look similar. So Worden tells us that the main difference between grief and depression is that grief doesn't involve the loss of self-esteem that is seen in depression, right? There's that quote up on the slide. In grief, the world looks poor and empty, while in depression, the person feels poor and empty. I think that's a really wonderful distinction. In the current DSM-5, it's left to the clinician to determine whether it's grief or whether it's depression and how the symptoms should be treated. Some people who have a history of major depressive episodes benefit from antidepressants, and the lifting of their depression helps them to then be able to examine their grief and their complicated feelings towards the attachment. My thought is just, if you decide to treat the depression through antidepressants, do not neglect to discuss the grief, right, in the talk therapy. All right, so now that we've got a solid grasp of what normal, healthy, crazy feeling, I'm dying feeling, I'm a confused animal feeling, healthy grief resembles, I want us to look at mourning. So if grief is the person's reaction to a loss, then Worden tells us, mourning is the process that occurs after a loss by which a bereaved person comes to terms with the loss. Again, mourning are the acts and behaviors of someone who is grieving. Grief is a feeling, it's an experience, while mourning is a process. So before we dive into this, what's the goal? What's the end game in the mourning process? Worden tells us there's always a sense of sadness when you think of someone you have loved and lost, but it is a different kind of sadness. It lacks the wrenching quality it previously had. Also, mourning is finished when a person can reinvest his or her emotions into life and in the living. Various grief scholars have divvied up mourning and its various tasks in various ways. I personally like Worden's work on it. So I'm going to spend a chunk of time now describing each of these 4 tasks, but a big word of warning, which is the tasks aren't fluid. A person can be grieving and feeling all those crazy feelings that grief entails and be simultaneously moving through the mourning process. They might move through the process in a really convoluted and zigzaggy way, or they're jumping back and forth between the tasks. but a person can still be in mourning. So what's nice about teaching your client about the tasks is it does give the client something to hold on to amongst the turmoil that is grief. And while the mourning isn't going to take away the pain of grief, these tasks are active and can help the client to make better sense of grief's intensity. So, task 1, to accept the reality of the loss. This hand here, that's a cast of Prince Albert's hand. So when Prince Albert died at age 42, Queen Victoria made casts of his hand, and the story goes, she then slept with these casts every night until she died at age 81, so for 40 years. Also, allegedly, after Prince Albert's death, Queen Victoria had her servants lay out Prince Albert's clothes, like fresh clothes for him to wear every single day, up until her own death 40 years later. So that's a really classic case of mummification, which is when the bereaved person keeps the dead person's belonging in mummified condition, ready for use when he or she returns. In the short term, mummification is not unusual, but if the denial goes on for years, the mummification stops the bereaved from accepting the loss's reality. Denial of the meaning of the loss is the opposite of mummification. It's saying things like, oh, he didn't mean that much to me. The death's really not that big of a deal, when we know that the person did, in fact, mean a great deal to the bereaved person. Denial of the meaning of the loss is an example of someone intellectually accepting the death. They're not denying that it happened. Yeah, I know they're dead, without the emotional acceptance. They're blocking the emotions and the pain of that grief, right? So it's important for our clients to accept the loss as reality, its literal reality and its emotional reality, in order to move through the mourning process. So how can we help our clients with task 1? One way is to avoid euphemisms and intellectual comments like the plague. So the most common euphemism is saying so-and-so passed rather than so-and-so died. In polite society, we say things like she passed all the time. I know that when I started counseling, I felt really squeamish using that word dead, instead of past, because I'd been taught growing up to use words like pass. And I've had to relearn and to just get over my own discomfort. Using euphemisms like she's passed or she's gone or she's no longer with us, she's gone to another place, it's not going to help our clients with this task 1, which is to accept the reality of the loss. Their loved one is dead. Also, avoid intellectual comments. She lived a long life. She's no longer suffering. These words may be intellectually true, but they're not helping our clients with the emotional piece, right? To feel, to accept that pain, grief. We want to encourage our clients to accept the painful, wrenching emotions that come when we realize someone is dead and gone forever, and intellectual comments can steer our clients away from that emotional aspect. And finally, we can help our clients with task 1 by asking questions about the person's death. Again, this is something, before I was a counselor, right? Frankly, I avoided questions about the person's death, right? I wanted to sort of like move politely away from it. Because I think that's pretty common in our society that we're avoidant over death. And I've had to do a lot of relearning to get myself just talking about death, right? So some questions we can ask our clients. Where did the death occur? How did the death happen? Who told you about the death? Where were you when you heard about the death? What was their funeral like? What was said at the service? It's straightforward, but it's kind of, I don't know, I find it funny how often we don't do these things. Anyway. So task 2. So often on the first day of the grief group, my clients will tell me, oh, I'm here at the grief group because I want to learn how to get rid of my sadness once and for all. And I got to then tell my clients, sorry, That's not the point of the grief group. We're actually here to feel the pain and not just obliterate it, right? So the second task is basically feel pain. So how can we help? And oh, this slide is one where I'm referencing the grief recovery handbook a lot. So before we can get clients to open up in processing their pain, it can be useful to have our clients acknowledge and identify all the ways they have not been processing their pain, all the ways they've been stuffing pain, even unconsciously. So first, I would suggest spending time with your client. Have them identify the various myths and miseducation they've implicitly learned about how to grieve. In the grief recovery method, we spend a good chunk of time in the group's beginning talking about how we relate to each of these various myths, how we were taught when we were young about how to grieve. So grieve alone. I know growing up, if I was ever sad, the message I received was, go to your room if you need to cry, right? Grieve alone. Be strong for others. Men and women both tell me how they felt this pressure to be strong for others, be strong for their parents, be strong for their little sister, whatever. Replace the loss. The classic example is getting a new puppy as soon as the old family dog dies, or getting a new wife as soon as the old wife dies. Stay busy. That's the myth. If I can only just distract myself enough, then enough days will go by and I can pass the time not thinking about what is bothering my heart, which leads into that last myth. Time heals all wounds. No, it doesn't. If we're just repressing the grief, if we're just pushing it down and not allowing ourselves to feel the emotions, then time is just, it's not going to just magically heal the wound. The wound festers. The grief recovery method also talks to us about Academy Award recovery, which is when grievers say, oh, I'm fine, right? And they look super together on the outside, and they're doing all they can to act recovered, and act like they're not grieving when they are, in fact, grieving on the inside. So we can educate our clients about why Academy Award recovery is not healthy. One reason is that the suppression of grief leads to long-term complications. Another reason is that when we suppress our grief, we cannot be emotionally honest. That is, we cannot get really honest about our feelings about the relationships, our feelings about the death, and without emotional honesty, we get stuck. The grief recovery method also asks us to identify STIRBs, which stands for, it's their cute little acronym for short-term energy relieving behaviors. So it's all the things we do to distract us from emotional pain, including but not limited to abusing drugs and alcohol. So a common one I see at the extended care program with all my, really Academy Award winning professionals is workaholism. So they bury themselves in work to distract themselves from that emotional pain. So in sum, at the start of task 2, have your clients identify all the ways they have not been processing the pain of grief through adhering to certain myths and misinformation regarding grief. And these are myths they might have learned growing up, right? Just implicitly, like their dog died and their family immediately got another dog. It's just an implicit way. This is what we do when we lose something. By putting on their Academy Award recovery faces and by using STIRBs to distract themselves from their grief. Also, educate your clients about why avoiding the grief's pain is not healthy in the long run, because emotional honesty is necessary to move through grief. After you've provided the education and misinformation piece, listen. Listen to your patients as they process that pain of grief. The grief recovery method tells us that grievers are not broken. They don't need to be fixed. They need to be listened to. They say we, the listeners, should be hearts with eyes, ears, and no mouths. And so that's what we need to do in task 2. Listen without analysis, without fixing, without using intellectual comments to rescue them from the pain. Just listen. All right. So the loss history graph is one of the first exercises we do in the grief group. And so this exercise is adapted from the grief recovery method, which is really good, and y'all should look into it. So I would invite you to do a loss history graph with your grieving clients, or frankly, any of your clients, whether they're actively in grief or not. It's a nice way to have them recognize all the losses they've had in their life, because we as a society are used to accumulating things, but we spend a lot less time acknowledging loss. And loss, it doesn't just happen in death, right? Loss is always happening. So I've put the instructions down here, and you can take a look afterwards. But basically, in a loss history graph, what you're asking the client to do is to jot down all the losses they've had in life from when they were born up until present day. So these include the obvious losses: deaths, divorce, loss of pets, losing friendships, loss of health due to illness. It will also include intangible losses, such as loss of faith, loss of stability. A lot of the intangible losses happen as a consequence of trauma. There's a saying, whenever there's trauma, there's grief, right? So for example, when someone is in an abusive home, they can lose stability. Sometimes a consequence of sexual trauma is a loss of faith. And the loss history graph will also include losses that come with good events, right? Such as the loss of freedom that comes with having children, or the loss of independence that comes with marriage. So they're basically gonna, I'm not gonna read the instructions, but they're gonna jot down all the losses they've had. I have them do a heart dump first, right? And just free write all the losses they've had from birth up until present day. And then they make a timeline. And I ask them to pick a variety of losses, right? From intangible losses to big losses, small losses, happy losses, whatever. And then the length and width of their line indicates the intensity of the loss. Sometimes there's a pattern, sometimes there's not, but it's a really good way to start a conversation just about how we grieve and loss. So here's another example. So you'll see that the grief goes from birth up until present day. And some of the lines are short, right? Like there's the death of her grandfather or the death of her cat. And these are pretty short, right? They didn't have that much of an emotional impact. There are other ones where, like it says, mom starts law school. I don't know if we would normally think of that as a loss, but this person did. She lost her presence, right? And as the lines, notice also that then there are good events, good losses too, right? There's up there around 2018, marriage, kids, job, and she said that was a loss of independence. And she also put loss of her addiction as a loss. So the idea again isn't to, it's almost, the idea between the loss history graph is basically to normalize loss and just get us looking at all the kind of losses we have. And then another thing I often have my clients do is once they've done this initial graph is to overlay it with all the myths and misinformation they've learned about how to grieve. Like, how did you grieve Joey Bobcat? Oh, we bought another cat. Okay, that's how we grieved it, right? Or how did we grieve, I don't know, something else? Oh, we just didn't. We were strong for others. So this can be then a starting point for other conversations about the myths we have about grieving. So task 3, to adjust to a world without the deceased. So Warden's third task is to adjust to a world without the deceased, and he lists 3 adjustments that the bereaved needs to make: external, internal, and spiritual. First, external. So let's say Bob loses his wife, Jenny. In losing Jenny, he lost his lover. He also lost the person who helped him exercise, the person who cooked him dinner, the person who did all the gardening, his Scrabble partner, etc. The point here is that Jenny was Jenny, his wife, but Jenny also played many different roles for Bob. She was cook, exercise coach, friend. These different roles can be categorized as the secondary losses that Bob is experiencing while losing Jenny. And oftentimes we don't realize all the roles that someone plays until that person is dead. So there will be external adjustments here that Bob will have to make in his life, and the counselor can walk with Bob as he makes these adjustments. And many of them are going to be quite practical, right? Supporting Bob as he learns how to garden and how to cook. It's common for people to feel resentful and insecure as they learn new tasks that the deceased used to do for them. But eventually, they become more confident in their newly acquired skill set and can come to the awareness that they actually like having these new skills. So we counselors can bring awareness to our clients about the new skill sets they have acquired. And this is referred to as redefining the loss. And it's an important dimension of meaning making. And it's part of the successful completion of task 3. So Bob would have successfully redefined the loss and created some meaning from his wife's death once he moves from saying, I'm totally helpless without my wife, to saying, you know, in Jenny's death, I've learned to garden. And I've learned that I really love gardening. So it's sort of a positive meaning that's coming out of her death, an unexpected positive meaning. Redefining the loss allows the bereaved to see positive aspects of the loss, not just negative aspects, right? And to find a meaning in it. Moving on to internal adjustments. So there are 3 aspects of internal adjustments: sense of esteem, self-efficacy, and sense of self. A key question we can have our clients ask themselves is, who am I now? How am I different from loving him or her? So as our clients work on their internal adjustments, we sit with them as they address how a death has impacted one's sense of self. So if internal refers to one's sense of self, then spiritual refers to one's sense of the world. There are 3 basic assumptions that are often challenged by the death of a loved one: that the world's a benevolent place, that the world makes sense, and that the person herself is worthy. As counselors, we can sit with our clients as they begin to find new beliefs, new meanings, and modified meanings, right? Often these new beliefs will reflect the fragility of life and the limits of control. When the task does not happen, and when there is a failure to adapt to the loss, the bereaved may withdraw from the world, and they may promote their own helplessness. Task 3 is really important. So I love the quote by Bowlby that's on the bottom of this slide. If the griever does not get through task 3, they remain in a state of suspended growth in which he is held prisoner by a dilemma he cannot solve. Finally, I just want to note that the process of meaning making is more important than the meaning that's made, right? It's that process, that journey of coming to a new meaning that is healing. So I love this image so much, I put it in twice. It's this idea that grief starts as an impossibly heavy load. And by the end, grief becomes the smaller purse, right? Our grief is something we will always carry with us, but it's no longer overwhelmingly heavy. So as Warden says in task 4, we counselors help the bereaved find an appropriate place for the dead in their emotional lives, a place that enable them to go on living effectively in the world. The goal of task 4 is really answering this question: how do we remember and how do we incorporate the dead into our identity while moving forward in our lives? We can do this by realizing that their influences, inspirations, values, meanings are still with us. And we can actively incorporate these aspects of the deceased into our new patterns of living. So again, some ways people can remember the deceased through objects, rituals, right? Rituals, going to the grave, visiting their grave. It's a way to remember the dead and we still move on with our lives. Thinking about shared values, shared meanings, and personal characteristics. So to review, these are all the principles we'll use to facilitate uncomplicated grief. Again, I'm not going to read that for you can read that yourself, but check out the cartoon on the right. This is what not to do, and this is what we're going to want to avoid. The fallacy that grief is fast and can be quickly dispensed with. Right? So a big part of what we're doing here is 6 and 7, providing time to grieve, again, at least 2 years, and normalizing the pain of grief, normalizing those emotions, those cognitions, behaviors, and physical sensations. And as we're doing 6 and 7, we can work through, in a cyclical, not necessarily straightforward fashion, the 4 tasks of mourning. So remember, grief is not a linear process. Neither are the tasks of mourning. And when we try to force grief into a linear process, what we're going to get into is complicated grief. So I'm going to spend this next section examining complicated grief, which is essentially what happens when grief gets stuck and when people suppress their grief and fail to mourn. And in complicated grief, here's where we see people turning to drugs and alcohol as a way to, quote unquote, deal with their grief, right? So referring back to that bidirectional arrow, we saw how addiction leads to grief. And in complicated grief, we see how grief can lead to addiction. So I want us to go over why some people fail to grieve, because understanding why our clients are failing to grieve will in turn help us to help them with that grieving process. Warden has a lot here, so I'll highlight what speaks to me, what I've encountered a lot of, right, at Bradford. And if you're interested in this stuff, please read Warden's book. It's a gem. So for that first factor, relational, we need to consider the kind of attachment that the person had with the deceased. The first one, highly ambivalent relationship with unexpressed hostility. This is a kind of attachment style that I see a lot of in the grief group and just working in Bradford in general. This is the client who is always bursting into tears regarding their dead mother and talks about how their mother was their hero and the best person ever. But upon further investigation, it becomes clear that their mother was extremely controlling, fat-shaming, verbally abusive, and overlooked the father's physical abuse. So the client is mortally afraid of saying anything bad about the dead person. In other words, it's the relationship where the person feels anger and ambivalence towards the dead person, but they do not feel safe expressing that anger and ambivalence. So what happens as a result is that the person isn't able to fully grieve because, as we know from tasks 1 and 2, particularly 2, fully grieving would mean coming to terms with all of the feelings, processing all of the pain of grief, right? Which includes anger. Due to this ambivalence and unexpressed hostility, the person cannot fully grieve the dead, right? And then these unexpressed emotions result in excessive amounts of repressed anger and guilt. Jumping over to personality. Another risk factor for complicated grief. People who are unable to tolerate extremes of emotional distress and withdraw in order to defend themselves against strong feelings. Of course, there's going to be a major overlap with our population, which is people who use substances. As they say in Dharma recovery, addicts don't like suffering, especially emotional suffering. And another personality type that's at risk for complicated grief, one that I see a lot of at Bradford's extended care program, are personalities that do not tolerate feeling dependent on others, right? These are folks with major defenses built around feeling helplessness. So why is that a risk factor for complicated grief? Because grief demands experiencing helplessness. Helplessness is a normal, universal feeling in grief. As we know, it's important to process all the emotions to mourn fully. So folks who have major defenses around the avoidance, major defenses around feeling helplessness, are likely to have dysfunctional reactions. They're going to be wonderful at being strong for others and putting on their Academy Award recovery faces. And they'll do everything they can to not feel their grief and that normal feeling of helplessness. As Worden says, the individuals who normally function most competently on the surface may be the very ones who are thrown most heavily by a major loss as it strikes at the core of their defensive system. Which ties into social factors. So there's the societal pressure as a risk factor for complicated grief. And there's an immense societal pressure to grieve quickly, right? That's why we got to put on our Academy Award recovery faces and just get back to work. Oh, we'd be lucky if we get a week off, right? It's not long enough to experience our grief. And then I've spoken to this a lot, but yeah, the societal pressure puts us at a risk for complicated grief. And that suppression of grief, the failure to mourn, and we can't really mourn if we're suppressing the grief, will often result in complicated bereavement. So complicated bereavement has been given a lot of names: pathological grief, unresolved grief, complicated grief, chronic grief, prolonged grief, exaggerated grief. Worden goes with complicated bereavement, so that's the term I'll go with as well. And he defines it as such: the intensification of grief to the level where the person is either overwhelmed, resorts to maladaptive behaviors, or remains interminably in the state of grief without the progression of the mourning toward completion. In normal grief, the transition, however painful, is neither overwhelming, interminable, nor prematurely interrupted. Note that Worden says a diagnosis of complicated grief shouldn't even be considered until the first anniversary of death. So some folks debate this and argue that an earlier diagnosis can lead to earlier treatment. Respectfully, I prefer Worden's timeline. Don't give diagnosed grief as complicated until a year out, because frankly, grief is ugly and messy and emotionally painful. That's just part of what grief is. And when we pathologize, we run the risk of complicating it further. Currently, the DSM does not have a distinct diagnostic category for complicated grief. The DSM acknowledges that a diagnosis could pathologize grief and bring in unnecessary medications. But now the DSM does add persistent complex bereavement disorder as a candidate disorder in section 3 under conditions for further study. So basically, as Americans get more interested in early diagnosis and mental health and psychotropic medications, these categories are beginning to shift. I do want us to note that in complicated bereavement, the focus is on how the client is mourning the bereavement, and it's not about the grief itself. Again, there's nothing pathological about one's grief. It's the way someone moves through the process of grief, the bereavement, the mourning, that can become muddied. So here's an inventory you can use with your clients. You can refer back to this slide or Google it. It's useful to not use this inventory right away, not for the first year, just because we have to let our clients go through the normal grieving process. But after a year, it can be a good starting point for conversation. So, types of grief reactions that are common in complicated bereavement. Chronic grief reactions. That is, the grief does not resolve itself over time, but remains chronic, lasting years and years and years. So you may hear your client saying, I'm not getting back to living. Also, some folks with ambivalent attachments, remember those people who call their mom a saint, but actually hold a lot of unexpressed anger towards her? They, in their chronic grief reaction, might be yearning for a relationship that never was, right? So they're yearning what they wanted the relationship to be, what they wanted to be different, better, or more in the relationship, and to have a resolution that they never got to have. Delayed grief reactions happen when a current loss triggers a person to start grieving a past loss. So in the past, your client may have experienced a loss that they did not grieve, or they only grieved a teeny tiny bit and then suppressed. Then, years down the road, the client experiences another loss, and this time the intensity of the grief appears excessive. What is happening is that the grieving from the first loss is getting carried over into the current loss. So for this reason, it's always wise for us counselors to ask our clients about their previous losses and how they were mourned. Exaggerated grief reactions. Here, the client will become overwhelmed by their emotions and may resort to maladaptive behaviors, such as substance abuse. Their experience may lead them to get a DSM diagnosis, right? The chronic grief may get diagnosed as depression or anxiety. It can also lead to substance use disorders. I said that. So what leads to an exaggerated grief reaction? In my experience, oftentimes what leads to that sort of exaggerated response is that ambivalent attachment with unexpressed hostility. Again, my mother was a saint, but she actually wasn't. That kind of relationship. So when the person is repressing a lot of anger or confused, ugly feelings towards the dead person, but they cannot get honest with themselves, and they get stuck in this loop of she was a saint, he was my hero, they never did anything wrong, no. When there's this absence of emotional honesty, that can then lead the person into this exaggerated grief reaction. And finally, masked grief reactions. If a person doesn't express their feelings of grief in an overt manner, say through mourning, then the unmanifested grief is just going to get expressed in some other way. The emotion will still get out somehow. Masked grief reactions often manifest as psychosomatic complaints. Sometimes the grievers will complain of the same physical symptoms as the deceased and will experience facsimile illnesses. They may also resort to maladaptive behaviors, such as anorexia, or acting out, or abusing drugs and alcohol. Our job as clinicians is to help our clients see that these seemingly unrelated behaviors are, in fact, grief reactions. This is because unlike in, say, exaggerated grief reactions, in masked grief reactions, the clients don't even recognize that their behaviors are stemming from their grief. All right, so in the previous slide, we looked at common reactions for complicated grief. Two of them tie explicitly into substance use. People with exaggerated grief reactions may turn to substances to self-medicate from the intensity of their grief, and people with exaggerated grief reactions may turn to substances to self-medicate from the intensity of their grief. And people with masked grief reactions may turn to substances as a means to mask their grief. So there's often an overlap between people with complicated grief and people with addiction. And again, there's that bidirectional arrow, right? So folks with complicated grief are at a higher risk of developing addiction, and folks with addiction are at a higher risk of developing complicated grief. I believe a lot of this is due in part to underlying personality types. Both folks with addiction and folks with complicated grief are going to have in common that personality type that screams, I cannot tolerate emotional pain. I can't stand suffering. And their psyches will do everything they can to repress and drown out and ignore the pain of living, as well as the pain of death. So how do we help our clients with complicated grief move through the grief? Working with clients with complicated grief is going to be slightly different than working with clients with uncomplicated grief. First, create a contract. Time limits. Worden suggests spending approximately 15 sessions on the grief. Clients with complicated grief may squirm. They will not want to talk about the grief because it feels too painful. They'll dodge the grief if given the option. We don't want to give them that option. On the other side of the spectrum, some patients with complicated grief may remain too stuck in their grief. These are the ones with ambivalent attachment, with unexpressed hostilities, and with exaggerated grief reactions. Our work with the client will be in assisting them to move forward in their lives and to not linger in that grief indefinitely. Create a groundwork of positive memories. So a lot of folks with complicated grief are going to have these ambivalent attachments. They're going to want to stay on that "my mother was a saint" wagon, and will not feel comfortable speaking about those unpleasant memories they have of their saintly mother. But this resistance to speaking their emotional truth is what keeps these clients stuck in complicated grief. Our task will be to assist the clients in becoming emotionally honest, in voicing their hurt, anger, and disappointment towards the dead person. We will be able to do this with more success if we start out with that groundwork of positive memories, positive characteristics, and pleasant memories of the dead. You and the client can always touch back on these positive memories when things get rough. Once you've built that groundwork, you can gradually ask your client about more mixed memories, and then lead the client into a discussion of memories of hurt, anger, and disappointment. As you begin to incorporate those ambiguous feelings into your discussions, you will then assess what mourning tasks the client struggles with. Tasks 1 and 2, struggling to accept the reality of loss and struggling to accept pain of the grief, often revolve around those ambivalent relationships towards the dead, where the person is, again, afraid of saying anything bad about their hero father or saint mother. And so they simply refuse to talk about that anger and ambivalence. And they're only focusing on those positive emotions or the more acceptable emotions. If the patient is struggling with making external adjustments, then the clinician can help the client with problem-solving skills and use role-playing to practice new skills. For those who struggle to find meaning in the loss, the clinician will explore with the patient what that meaning might be, and it will explore how the loss has affected one's sense of self. For clients struggling with task 4, how to endure a connection with the deceased while moving forward in life. Sometimes the best thing we can do as clinicians is simply give the client permission to move forward, to sanction new relationships. Do you need permission to start a new romantic relationship? I give you that permission. I want to spend this slide going back to the grief recovery method and some of the language they use in that book, because the language they use to get folks to open up about their relationships is super useful, and I encourage y'all to borrow it. So the grief recovery method talks about how some grievers fall into the trap of enshrining or bedeviling their deceased loved ones, right? So focusing on only the good memories is enshrining, or only the bad stuff is bedeviling. In both cases, it's a protective factor against the intensity of grief. If I enshrine you, that I don't have to face my anger. If I bedevil you, then I don't have to face my sadness. The grief recovery method also argues that total emotional honesty is key for getting complete with our grief, for the same reasons I've already discussed. And the grief recovery method also uses the language of different, better, or more. That is, they have us ask, what do you wish had been different, better, or more in the relationship with your lost loved one? This language, different, better, or more, can be far less daunting than saying, hey, what did you not like about your saintly mother? It's an indirect way of getting people to speak freely, one that bypasses their defenses. In the grief group, we also have our clients create a relationship graph, looking closely at the relationship they had with their lost loved one. It's a similar setup to the loss history graph, where we put positive events on top, negative events on bottom, and the length and density of the line indicates the intensity of the emotional experience. When creating the relationship graph, we're asking clients to think about memories where they wish things had been different, better, or more. Also think about memories which had an unspoken communication. I wish I had said this to them. I wish I had told them I love them. I wish I had thanked them, but I never did. Or I'm holding a resentment with the person with regards to this memory. Or I need to apologize for how I acted or failed to act in this event. I recommend y'all use the relationship graphs with your clients, especially those clients who have ambivalent relationships with the deceased, when they're unwilling to get emotionally honest. It's a really useful tool for creating that emotional honesty, as is this language of what do you wish had been different, better, or more. All right. So for the final section of this presentation, I'm going to turn to Julie Bates-Mave's work, which looks at addiction recovery as a form of grief. And it's a more expansive definition of grief, right? So Warden's focusing on grief as the loss of a loved one to death. Now we're considering grief as just that experience of loss in general, right? So Julia Bates-Maves, has a really interesting take on addiction recovery, because in recovery, we do tend to focus on the gains and not the losses. But Bates-Maves argues that we're missing something important when we only focus on those gains and when we don't acknowledge the loss and the grief that comes with the loss of an addiction. An example of the loss. We tell our recovering clients to avoid people, places, and things that are triggering. There's loss in that, right? So I'm thinking of one of my patients, and we were on this Zoom family call, and his wife said to him, hey, I look forward to you coming home because we can, watch Netflix in the evening together again. That's something they've done every night. And my patient, without a beat, he just said, no, I can't do that anymore, because watching Netflix at night was the time where I always had my whiskey next to me, and I need to avoid triggers. They've taught me in rehab to avoid people, places, and things, so I just can't watch Netflix with you at night anymore. There's a lot of loss there, right? There was a lot of grief in that statement. And there's this temptation for us as clinicians to simply pat the guy on the back, say, hey, you're doing the next right thing. You're identifying your triggers. Good for you, right? And just totally brush over the grief that's in the movement. And we're doing a disservice to clients when we brush over these secondary losses, because the client will feel them, even if the grief goes unspoken of. There's also the primary loss of the addiction itself. That drug was there for you, for your client, whenever she had a bad day, whenever she went through a breakup, whenever she felt alone, whenever she had a good day, right? Bates-Maves compares addiction to a romantic relationship, and losing the addiction is like losing a romantic relationship. Bates-Maves suggests doing a loss inventory with the patient off the bat, and this can be a starting point for conversation. There's an importance in acknowledging and just naming all that has been lost in one's addiction after one's addiction. And doing an inventory like this, an inventory of all that's been lost in the addiction, those primary and secondary losses, is a way of helping our patients with task one, which is to accept the reality of their loss. Because the reality is, in recovery and in the course of the addiction, they've lost far more than the drug. And this is just more of the addiction model. So task 2. In order that our clients process the pain of grief, we need to avoid those keep looking ahead comments. The keep looking ahead comments in early recovery are the equivalents of euphemisms that we make when someone's died, right? He passed, she went to a better place, and those intellectual comments. She's no longer suffering. So they're serving the same function, which is to prevent the client from processing the pain of grief. Keep looking ahead comments can sound like, it's time to move on. You're overthinking this. Just keep looking forward. Don't look back. Don't look back. And the issue is that while these comments are well-intentioned, they can sound dismissive and ignore the pain that comes with leaving an addiction. Also, comments like these can cause unintentional shame and guilt around the fact that people are experiencing emotional pain, right? It can invalidate their emotion. Instead, why don't we explore the loss of addiction with them? Explore that grief in losing their addiction. Some conversation starters include, I know you're trying, and I know there are things that are keeping you where you are. Let's talk about them. Tell me about what you're missing. What do you wish you had more of? Do you think it's possible to find it any other way aside from the addictive pattern of use? What are you scared to lose in losing your addiction? What do you miss about your addiction? These questions are designed, again, to get clients processing the pain in losing their addiction. Task 3, to adjust to a world without the disease. External adjustments are pretty straightforward. So some things you can do with a client include identifying triggers, right? People, places, and things. Supporting clients as they establish new routines and behaviors that can involve role playing. I love role playing. And celebrating gains, financial time, right? More time in our hands, more money in our pockets. Here are conversation starters to get clients exploring internal adjustments. That is, self in relationship to self. Who are you without your substance? Do you have hope that you can keep the good parts of yourself and change the bad patterns you've got going on? What gives you that hope? How much of yourself have you lost to your addiction? How much does the past define you? How much power does it have in your life? What needs to happen to shift that balance of power? Talk to me about the things you like about yourself. How successful do you think you can be on your own without the addiction? And finally, some questions to get conversations going about spiritual adjustments, which is self in relationship to the world. How has your addiction changed the way you see yourself in the world? Have your experiences changed the amount of hope you have? Do you tend to believe the world is a safe place? Is it safe for you? Do you see the world any differently now? Do you want to? Think about how you've been treated by others through your addiction. Have any of those experiences influenced how you view people? So working in a rehab, there are some comments that I've learned to absolutely dread. And when I hear them, alarm bells go off and I think, crap, this person's at a real risk for relapse. The comment I dread the most is, I'm totally better now. I'm a whole new me. That addict version of myself is dead and buried. I'm going to walk through the gates of Bradford and be a brand new person. Past is dead and gone, right? So that comment is a warning bell to me because it's similar to what Warden talks about, right? Way back in the beginning, which is denial of the meaning of the loss. And it's a warning sign to me that task 1, to accept the reality of the loss, has not really sunk in for the patient. Or if it has sunk in, the patient is repressing and not allowing themselves that emotional honesty. A similar comment that I sometimes hear that kind of makes me cringe is, all those things I did while I was in my active addiction, that wasn't me, that was the devil. The devil got a hold of me. Working in the Deep South, in the Bible Belt, I do get some of these hyper-religious comments, and they make me nervous too, because in both cases, the patient is denying the meaning of the loss. The fact is, we will always be connected to our addict selves. We cannot totally shut the door on that. And we run into trouble when we attempt to do so because it entails denial and emotional dishonesty. So as counselors, what we can do from the beginning of our work with our patients in early recovery is to help our clients to connect to their addict selves as they move forward in their lives, and to connect to a self in a way that draws out a sense of survival and strength versus shame and doubt. Bates-Maves, as she talks about the importance of retaining a connection to that addict past, reminds us of the continuing bonds theory, which is a theory in grief therapy that states that death does not sever the relationship, it merely changes it, and that it is healthy and normal to maintain a relationship to the deceased. So what would it look like for an addict to maintain, an addict in recovery, to maintain a relationship with their past addict self? Bates-Maves says that maintaining that relationship, some form of connection to the former addict self, may actually promote recovery rather than threaten it. It provides reminders to remember where they've been so they won't go back. It provides compassion and empathy for their formerly addicted selves. It increases awareness of strengths that existed during the addiction. And it helps clients to disown aspects of themselves that might lure them back towards addictive patterns or tendencies, such as reliance on external means in order to cope, narrow thinking patterns, low self-worth. So at first glance, her suggestion may sound more out there than some addiction recovery methods that's always, focused on moving forward. But I actually think that what she's saying resonates a lot with the 12-step method. Remember in AA, the 9th step promises says, we will not regret the past nor shut the door on it. So I know in this talk, I've spoken a lot about how folks with substance use disorders are at risk for complicated grief and vice versa. And that might sound a little daunting, but as I close up this presentation, I do want to end on a good note, which is this. While folks with addiction may be at a higher risk for complicated grief, I believe that folks who are working a solid recovery program are uniquely well suited to work through their grief without those added complications. It's because AA is all about acceptance and emotional honesty. Remember, in the big book, we're told that those who do not recover are those who are unable of being honest with themselves. AA tells us that we need that emotional honesty in order to recover. And that's the exact same thing we need as we move through our grief. So for folks working a solid recovery program, they're used to acceptance, emotional honesty, and they have practice in feeling their feelings without necessarily acting out on those feelings with maladaptive behaviors. And then, of course, they've got their good support group, and community is such an important part in the grief process. So on that good note, I'm going to wrap up. And if you're interested in where I got my information, including some of the illustrations, you can check out my source page over here. Marie Andrews is really cool, and Anders Nilsson also. So that's it.
Thank you very much, Anna, and to Karolynn, our first speaker. Very much appreciate the information, and the chats certainly indicate the audience's appreciation for your time this morning. We do have time for some questions. Before we get to those, I do want to remind the audience of things that I've heard from both speakers throughout the morning, and that's that with the nature of this topic being a pretty heavy topic, and certainly saw that being reflected in the chat, many people experiencing personal connections with this topic. Please take care of yourselves and each other through this time, and please check in with yourself on anything that you might be needing, and reach out to colleagues, peers, and family if you're feeling so compelled. We tried to have a balance of lighter aspects of the topic, but I commend both presenters for being so engaging throughout, and trickling in some humor where we could in the topic. But so for our Q&A session, and I appreciate what's coming in. Keep questions coming in if you want to keep sending them in chat. I'm watching, and Q&A function in particular. Here's a few that have come our way. What I'm going to do is I'm going to direct these specifically towards one speaker to start, but then I will give time if the other speaker would like to provide any additional insight, counterpoint, or opinion. Don't feel like you have to, just give any of the options so we have the time. First question I'm going to send over to Karolynn. You had very early in the presentation some discussions about stuck points and the cognitive distortions that you're working with the population that you're serving. Can you spend a couple minutes maybe elaborating on some of those things? What are some examples of what you see in this area in your work specifically with the population, and maybe if you want to carry that forward into some things that you do in particular of addressing those, or perhaps maybe some friction points yourself in that work.
Yeah, absolutely. So to start, the stuck points or the cognitive distortions with the CPT model, the first thing I want to say about really working to identify stuck points with patients is that the most important element seems to come from them saying their stuck point out loud in their own words. I think that's true of a lot of different intervention techniques, but really, especially with the cognitive model, I've found through some trial and error as I've gotten, amplified my skills over time with CPT, that when they really lay the foundation of what the stuck point sounds like to them, there seems to be more resolution as far as outcomes. So they seem to show a much higher level of progress on the stuck point when it's derived from them. So what I mean by that is in my Socratic questioning, when I'm really tap dancing around all the different ideas, and I even showed some examples of questions that I use in my work, and really using that open-ended model, right? So how do you feel like this trauma impacted your sense of self, your identity? How do you feel this trauma impacted your self-esteem or the way that you feel other people view you? So one thing I see often, sexual assault is certainly a trauma that I work on a lot in the women's program. I think I skipped over that with some nerves in my early part of the presentation, but sexual assault, abortion, which is certainly a trauma for many individuals, being forced to carry a child, infertility issues, all of that is very common stuff that seems to surface in the women's CPT group. So from a sexual assault standpoint, if that's the index trauma that we're working on, some examples of common cognitive distortions are sense of self-blame. So it was my fault. This happened because I didn't do X, Y, or Z. Insert their narrative there, right? This happened. I believe that this trauma happened because I shouldn't have been alone. I believe that this trauma happened because I'm an alcoholic. That's one that surfaces a lot. I believe that this trauma wouldn't have happened if I wasn't using, which ties so much into a lot of what we've talked about today. I also see a lot of distortion surrounding body when I ask questions about sense of self, right? So body and self-esteem. So one I get a lot is, I am dirty. I am not lovable. I am worthless. So very concrete, all or nothing. And it's interesting, sometimes you'd think that stuck points are a little bit more complex, but when we really boil them down and do some intense processing, it always seems to come to like a 3-word sentence, like I am this, or this is this. And them saying that piece out loud to themselves is the first transformative piece following the impact statement. And then the peers hearing it, reflecting it back, and then me hearing it and reflecting it back to them of what I'm hearing. So that's a big thing. As far as the second piece of what you asked, as far as like any advice on how to address those, I think when they come up, one thing that goes with both parts of our presentation today, I really like to use this simple little tidbit, which is when I see someone really sitting with that emotional activation, especially for my primary avoidant clients, if their PTSD presents as mostly avoidant in their coping skills, but I can see the emotional activation really being there for them, or them being on the brink of tears, I might lightly pause and interrupt and say, I'm gonna stop you there for just 1 second. I just want us to pause on this. I want you to really picture whatever emotion's surfacing for you right now. And I'll even do this in group. I want you to picture what emotion's surfacing for you right now. Feel that. Feel that in your heart and in your spirit. Usually them feeling like they have to truly sit with it in that moment, and that they're challenged to do so, allows them permission to expel that. And sometimes I'll even use the language, if some of their distortions are surrounding what it means to be vulnerable and to cry in front of people, or emotional deprivation or inhibition, I might say, give yourself the permission right now, even in this safe space, even with people present, give yourself permission to feel this right now. And it's kind of surprising what that safety language, or what that extra 30 seconds can do for the trauma processing, because when the emotional and logical ties in, yet again, there's so much more resolved with the stuck points. And so incorporating the emotional piece as much as the logical piece is super imperative to the CPT intervention.
Thank you. Very comprehensive answer. And anything you'd like to add to that? Of course, no pressure. It was directed specifically at Karolynn. You can pass, and I can throw you another question if you choose.
To be honest, I was just thinking, man, I want to do training in CPT as she was
Right
talking.
on.
And then
Right
I was thinking, oh crap, I got to follow up and her answer.
No, you don't. So I'm going to throw this question your way. One of the slides that struck me early in your session was speaking about the grief that we're collectively dealing with in this country with the opioid epidemic and the rampant use of fentanyl that's causing so many overdoses in our local communities as well as our nation. Can you speak to how that adds a layer of complexity with the population that you're serving? Because I undoubtedly believe that you're having so many people come into treatment who have lost people due to their addiction, and there's a lot tied into that, especially if these were people that they were using with. Or sharing supplies and things like that. The rate at which we're losing people right now is unprecedented, and that must be weighing heavily on people, probably more than it ever has in recent history. So how are those kind of things enveloped into what you were speaking about with some of this processing of the grief?
Yeah, I mean, as you were asking that question, I was thinking about a man I worked with who, in the grief group, whose friend had overdosed with him. And I see that a lot. I see that a lot, where people lose folks to overdose. And with that, there can be the shame, there can be guilt, there can be feelings of numbness, all of it. I'm thinking about how to answer the question except to say like yes, yes, and yes. In the grief group, I will add this, when we do the loss history graph, because oftentimes that's not maybe the primary loss that they're focused on. That's just, so the first thing we do in the grief recovery method group is that total loss history graph. That's just all the losses we've experienced. And of course, with folks in addiction, there's a lot of losses, a lot of losses. And sometimes I'll have patients who as will grieve their addiction as the grief they're focused on. And that gives them an opportunity to forgive themselves, apologize, forgive other people. I don't know if I'm really answering the question, except to say yes and yes and yes. And that grieving one's addiction is, you can do a relationship graph to one's addiction, and it gives one the space to voice all the complicated emotions one has.
Very good answer. It is absolutely sufficient to have the answer of like the question, yes, and then say whatever you want to say. I really like the idea, and I don't recall it specifically talked about in the presentation about doing the graph of the addiction itself. I think that that's a very useful tool, and I know many members of our audience aren't necessarily working only in the addiction space, but that could be an area to open up some dialogue about some of the impact of the events and the thoughts and feelings around those events as people have gone through that using journey, but then initiating their recovery journey. As we know, that happens in so many different settings, not always in places like Bradford and Cornerstone, but in the offices of our outpatient individual counselors all throughout the country. So these are very manageable exercises that I think pay a lot of dividends. So I want to turn, I'll throw this one back to Karolynn. We had a lot of very positive feedback on your slide about the 4 stress responses. I was reading people who were appreciative about including the other aspects of it. We usually just talk about fight or flight, and that's all it is. So additional context there. How do you see, and tell me if you don't, but do you see this playing itself out in the recovery communities, in the therapeutic community, where people have gone to this seemingly as a defense mechanism in many ways when they're dealing with stressors in their lives, and then they're dealing with a lot of stressors of being in treatment and early recovery? So what are some ways that you see this playing out in the community with the fight, flight, fawn, and freeze?
Yeah. Yes, yes, yes. Just like Anna said, I think we definitely can be looking always through a trauma sensitive lens. And so when we're doing that, we can acknowledge people's behaviors in that way. So one thing that I didn't include that I think is a good piece to add here is that when we think about flight, I feel that we can also see that with individuals with high risk of leaving against medical advice, right? These emotions are way too painful. Sitting with this for the first time in my life feels awful. It just does. And I need to resort back to an old coping skill and get up out of here because these people are making me feel lots of stuff and I'm not down with it, And I think while that might sound like oversimplifying, I really do think a lot of it comes to trauma response of people leaving treatment or people going into relapse mode. It's some sort of way to grab onto the coping skills that we've known. And human beings are creatures of habit. So we love to do what we know to do. And we can also acknowledge that for patients. That's a validating response, right? This is what you've always done. This is what you've known to do. And so another one that I see, these stress responses also operate in the group setting, which gets my nerd brain fired up because the way that people respond to each other is always so interesting as a facilitator, right? So when conflict management comes from the group, your individuals that usually struggle with day-to-day fawn response from toxic stress are going to get easily affected when there's absence of conflict resolution among the group. So if the group is divided, your individuals with fawn response are certainly going to be the ones that are going to engage in that excessive people pleaser. So your individuals with fawn response are probably going to be sitting within themselves, especially if conflict is arising in the group. They're going to be sitting within themselves. So closed in body language, trying to cope. This little thing can go with multiple sense of soothing, multiple different trauma responses, in my opinion, but the rocking, right? The rocking, if I see someone really sitting inwards and rocking. And then what I notice with fawn response that I think is also important to answer your question with is the idea that they struggle with peacekeeping rather than peacemaking, right? So people with fawn response want to keep the peace because the emotional reactivity feels too heavy and it feels like too much internally. So rather than moving into the conflict resolution, those are going to be your patients that probably can use the work on the assertive communication skills, because all they've known is to tend to the needs of the abuser or tend to the needs of the perpetrator. That's what they've known to do throughout their coping. So really tending to trauma responses, I think, shows up all the time, whether it be in the group dynamic or in individual and family therapy sessions. I left that out too. You can usually look at people's trauma responses to one another in family sessions additionally.
Everything's about systems, and as you brought up family, I was specifically thinking about your internal family systems theory that you referenced in your slides. Very much exactly what you're talking about. We'll repeat these systems in different settings. Anna, any addition you'd like to make to that before I throw a question your way?
I keep on just, I'm thinking as an audience brain, like,
Yeah.
man, because I also
She's just enjoying the presentation,
just
gang. She gets to sit back and watch now. Y'all have been here for a few hours.
Fawning.
All right. And this really could be a question for both, but Anna, we'll start with you. And I think it can relate back to some of the timeline interventions that you spoke about, but really just kind of the weight of grief and loss that is just so rampant. And I think we can all identify with it. At least I can personally. You get a client in, and they will often not just have one traumatic experience or grief experience. I think the example that was brought up in the question from an audience member was something like, if someone has lost someone at this age, then a few years later they went through a violent traumatic experience, and then this and then that. That's very overwhelming, especially for the clinician, but also the client. Where does one start? How does one prioritize getting into the work when so much, I think, of their attention is going to be on specific events and specific reactions? So how do you wade through that early in a client interaction?
I guess two things, I'm not sure. But one reason I like the loss history graph, as that's sort of the first exercise we do in the grief recovery method, is it doesn't have us pick one event, right? It allows you just to do that whole timeline on a sheet of paper. And one thing we do, and I sort of spoke to this a bit, but to expand, is when we're presenting the timelines, the clinician and the other people in the room, we are, to use the grief recovery metaphor, we are hearts with eyes, ears, and no mouths. So, in process group, we're used to the more CBT type stuff, like doing the analysis, asking further questions, giving feedback. This is how I relate. What are you feeling here? In grief recovery method, when we're sharing those graphs, I have like a sand timer for 20 minutes, and that's all it takes, because we're just listening. and we're just having the person just read through the graph. And oftentimes without the added words, like they might give like a sentence or two to backstory, but they're not going into that deep analysis. But without all that added words, a lot of the emotions come through. Like I think you were saying, where do we start? Sometimes I think of the grief recovery method and frankly, like rehab in general, it's just a primer, right? I remember when I first started working at Bradford and I had this idea that I wanted to like get into all the details. And then a more experienced clinician just said, you're not doing fine work, you're doing broad brushstrokes. And another clinician was just like, honey, this is triage, right? This is triage. We're just, but I see the grief recovery method and a lot of the works we're doing is keep giving them skills so that when they go out into the world, that great big world, they'll be better prepared for how to grieve further, right? They're not going to resolve all their grief in 12 weeks of treatment or move through all the grief, but they can at least lay out all the grief. And we can talk about the miseducation, the myths, the ways they've been repressing the grief, how that's not healthy, and get them started in that, like getting comfortable just emoting. I don't know. That's my attempt in there.
Thank you. Very, very good. Karolynn, any thoughts from your side? Prioritization,
Yeah.
as you're evaluating folks and starting that initial work, it can be very overwhelming for them. Sometimes even for us. How do you start?
So I think the way that I look at this is from how can we always keep people engaged in their recovery? Like, how can I best serve the life in front of me? So from my standpoint, I'm usually going to target, especially if someone's really, I feel like they're ready to do the work. I've had patients say to me, like, I just want to feel better. Like I've had people that struggle with a lot of dissociation to say, I want this out of my body, which is it, you know what I mean? However, the pain manifests for them. So I will target what is the highest level of activation. What feels the least manageable right now that we can't get to calm down? Because if we can lessen that response in their central nervous system, we can activate that parasympathetic and really hopefully my goal, even in just one session, how can we make this more manageable today? How can we have this not take up all of you for the moment so that you can get things out of your other groups, so that you can get things out of the rest of your treatment? And that's also just a tidbit kind of that I've learned from my mentors, right? Is go with the patient approach, right? What do they want to work on? What do they feel is most disturbing to them right now? So I usually go based on that, unless the opposite, right? Like if someone is highly avoidant, but I can feel, that just thing in my therapeutic gut that Anna mentioned, like kind of comes with experience, where it feels like someone really needs to work on this thing and there's a lot of avoidance. I might openly say to them, you're telling me you want to work on this thing and I'm fine to do that. It is absolutely your therapeutic timing. I also feel like I'd be failing you as your clinician if I didn't point out that I feel right now like there's some kind of avoidance with this topic. Do you feel like you didn't choose this because it's actually the thing that we might need to work on? And if their therapeutic rapport is good, a lot of times they'll say, yes, Karolynn, we'll do it, and I'm like, only if you're okay with it. And they're like, no, you're probably right. I need to work on that. Or some people will say, you're right, I need to work on that, but can we save it for next week? The answer, of course, absolutely. It's your therapeutic time. So that's my best answer to that, I would say.
Well, very good answers. Thank you both.
Can I add one more thing?
Absolutely.
Also to what Karolynn was saying, yes, that's all what I meant to say. But the grief recovery method tells us if clients are sort of vacillating on what relationship to choose when they're focusing, they say often to choose the relationship with a parent, with a primary caregiver, because that primary attachment style is going to say so much, of course, about other about how we've grieved other losses and other attachments. So there's always that. If I have a client, they'll be like, should I work on my relationship with my mom or my friend? I'm normally your mom.
Freud was always right. Got it. It always comes back to parents. All right. Y'all gave some wonderful references in the PowerPoint. Many books, articles you referenced. And as a reminder to everybody, we will be sending out a copy of the PowerPoint slides as well as a copy of the recording. One question that I saw asked by a couple people, where, other than the books, which we appreciate very much, where do you go for seeking out resources, trainings? What are things that you recommend? Whether that's going after EMDR training, certification, particular resources you look to. How do you stay knowledgeable in this space as much as both of you very clearly are? I'll start that with Karolynn, if you don't mind.
Okay. So one resource that I really like is Pepsi. I don't know if I'm saying that right. I think I'm saying that like the brand Pepsi. It's fine. But it's PESI, I think. And they will send you a lot of emails, but they have such a wide span of in-person trainings, online. Look, the chat's like, yes, Pessy, whatever she's saying. I think that's a really good resource because it has such a wide range of things. I don't know, someone just mentioned that some of the CEUs are not approved. I found it very valuable for knowledge standpoint. So like I did an IFS training on there that I got like a certification after, but I had to take a test. And some of the trainings can be pricey, but I do think that some of them are just really, really good as far as the clinical value of them and giving you tangible skills to use. Because I think sometimes we talk a lot about theory, but then we don't always go into tangible skills. That's why I wanted to incorporate some of that today. And so did Anna, because it's like sometimes you leave the presentation with, okay, now I know about this intervention. Now what am I going to do with that? So for that reason, I really like that website. And then of course, CEUs through Bradford. So there you go.
Oh, gold star on that call out. Well done.
I'm excited because I get to be a fangirl for a second. Okay, so there are a group of therapists in Springfield, Missouri called Beyond Healing, and they have the best podcast. It's called Notice That, and it's an EMDR podcast, but you don't have to be trained in EMDR or care anything about EMDR to benefit from it. They also have another one called Beyond Trauma and another one whose name I forget. They do trainings. They have a website where they have little webinars and book studies, and I have a major, major crush on them. And for the longest time, I still do this, like, because I have a half-hour drive to work, I just listen to them on the way to like get me in my fit. I love them. So
great call out. Thank you. Had never heard of that one. People are asking what is it called again? Let me
Beyond Healing. Beyond Healing Institute. And their podcast is called Notice That.
Thank you very much. Thank you both again for the wonderful presentation. We are getting to the end, so we are out of questions. This is going to conclude our session. As you may have seen a moment ago, we have posted the survey link in the chat. I'm doing it again. Pam has done it again there. You can grab that link right now if you so choose, and you can get that done today. We will be sending out an email with that same link. So if you miss it in the chat, do not fret. It's going to come to you in your email inbox later on. Be on the lookout for that post-session email. It's going to have content from today. You only have to complete the evaluation once. So if you do it from the chat, great, you're done. You don't have to do the one in your email. If you want to wait till your email, great. The important thing is get it done in the next 30 days. I know we're all very busy, but you got till the end of the year, literally. Get it done. That way we can give you CE credit and we will email you a certificate. We hope that you enjoyed today's session. This concludes our series for the year, and we look forward to seeing you back again in 2024. We are already planning our sessions. So feel free that when you do your evaluation, if you want to send us some suggestions for things you'd like to see in the future, we do read those. We do take account of those and put them into future planning. Know that we are a substance use treatment provider primary, so we always are going to take that slant on it. So if it's something outside of our scope, we are not going to touch on it. But the wonderful thing about substance use disorder treatment is it pretty much connects everything in mental health. So there's not a lot of things that we won't go into as long as we can relate it back to what we do here. So again, thank you very much. Grab it in the chat one last chance before we close up. Otherwise, you're going to see in your email. Have a wonderful end of your year. Safe holidays. We'll see you in 24.